Good morning. It's 1 minute to 9 a.m. and we are counting. So we will start the second day of National Summer CME of Pediatric Infectious Diseases soon. So those who are having breakfast, please come and join in the conference hall Pala.
Joydeep, let's wait for 5 more minutes. 5 more minutes, I think people will come. We'll organize repeat next year. Next year. I'll start. Let's start.
So good morning. We are starting the second day of this National Summer CME of Pediatric Infectious Diseases. So thank you for joining us. Yesterday was a very nicely interactive day for us, and the request to all the delegates and faculties to please cooperate with us in maintaining the time schedule and others. The morning starts with a session on neonatal sepsis, the changing scenario in diagnosis and treatment, and it's pleasure to have with us Dr. Rashna Das Hazarika from Guwahati as the moderator, and we have an expert panel of Dr. Ajay Gupta from Delhi, Dr. Ruchira Maheshwari from Noida. She is also the Honorary Secretary General of Central IIP. Dr. Devajit Sharma from Guwahati, and Dr. Preeti Khemka from Kolkata. So may I request the moderators and panelists to please come on stage, and those who are outside and having breakfast may please join in the morning session on neonatal sepsis.
মাইক দিয়েছেন তো ওখানে মাইক দিয়েছেন টেবিলের উপর
I welcome all our panelists on the dais. Ruchira, Ajay, Preeti and Devajitda, please come. So thank you very much to the organizers for giving us this opportunity. And the topic allotted to us is neonatal sepsis, the changing scenario in diagnosis and management. So just to introduce the subject, we know that neonatal sepsis still constitutes a major cause of neonatal mortality and morbidity worldwide. And the clinical syndrome of systemic inflammatory response in the neonates may be secondary to invasion by bacteria, virus, or fungi. The terminologies like suspect sepsis and confirmed sepsis, we all know that with or without a culture. But blood culture remains the gold standard. However, one has to understand that in all patients, bacteremia may not be there. There is also a huge problem of antibiotic overuse and emerging antibiotic resistance. But neonatal sepsis still remains under-recognized, and there is a lot of delay in treatment, which causes a lot of problem in these tiny babies. So timely recognition, diagnosis, and management is the need of the hour. So we'll have some questions for the panelists, and I'd request them to be very brief and to the point so that we can finish all the questions. The first question is to Dr. Ajay. Are the current definitions of early onset sepsis and late onset sepsis still applicable in clinical settings? Dr. Ajay.
So, good morning. Early onset and late onset sepsis, they are defined as onset within first 72 hours of life, or because these are most likely to be transferred from the maternal side. And the late onset, this is after 72 hours of life, and these are either nosocomial or environmentally acquired infections. But these clinical setting is more important because nowadays with the advent of newer molecular diagnostic methods and advanced point of care testing, etc., the microbiological diagnosis that takes a center stage because the treatment nowadays is based upon the organism involved. So modern neonatal care emphasizes maternal risk factor, whether there was any chorioamnionitis or premature rupture of membranes, or how is the infant doing, whether the condition is critical or not, and use of tools like Kaiser neonatal sepsis calculator and availability of molecular diagnostics has changed the treatment scenario. And microbiology matters more than the timing because the early onset pathogens, they are mainly group B streptococcus in the Western Hemisphere and E. coli in low to middle income countries. And the late onset sepsis pathogens are mainly coagulose negative staphylococci, Staph aureus, and especially in the NICU, the fungi. And the preterm babies often don't fit neatly because sometimes even if the child is showing symptoms on 4th day of life, it may still be transferred from the mother because of the incubation period. So a preterm infant on the day 5 infection may still have antenatal region of the infection, but the guidelines by WHO and the Western countries, they still rely on EOS and LOS, but now they're being used flexibly, especially the clinical condition and the microorganism involved, they matter much more. So in a takeaway, the real world neonatal care, EOS and LOS are still useful frameworks, especially for the initial empirical treatment and epidemiology and audits. But clinicians, they now prioritize risk stratification, clinical science, and local antibiograms.
Dr. Ruchira, you would like to add something?
May I add something? So recent lot of publications have come up where it was found that earlier the kind of demarcation used to be there in the pathogens of early onset sepsis vis-a-vis late onset
Correct.
sepsis. Now that is no more
No more
there.
there.
It's
Especially
no more
in the
existing.
lower, especially in our settings.
Absolutely, especially in lower resource countries setting.
Yes.
So here there is always a overlapping of organism in both the groups. So actually that demarcation no more exists grossly.
So Preeti,
It's difficult, yeah.
Yeah.
To take cut off. The specific date is difficult, yeah.
so Preeti, being the neonatologist here, do you have any different comment on this?
I agree with Dr. Ruchira
Yeah,
completely. We
okay.
are seeing an overlap in organisms,
Right.
especially multi-drug resistant organisms, even in early onset sepsis cases.
Right. Okay. So that is very important. Now, coming to Preeti, so I have a question for you. What is the role of physiomarkers in identifying neonatal sepsis?
So
Since we
moni-
said EOS, LOS, no demarcation.
So we know sepsis presents with non-specific clinical signs. So monitoring vital trends and patterns can serve as physiomarkers of sepsis by causing changes in physiology which we can monitor early. So what happens is when pathogen invades the bloodstream, the immune cells produce chemokines, cytokines, and several other inflammatory mediators, which activates the autonomic nervous system and manifests as changes in temperature, respiratory rate, heart rate, and blood pressure. Now, in early stages of sepsis, we can see depressed heart rate variability along with transient decelerations. Now, the HERO score incorporates both these measures of depressed heart rate variability and transient decelerations and displays a score on the HERO monitor, which predicts the risk of deterioration in the next 24 hours. So it analyzes the rhythm, the ECG rhythm and the heart rate of the preceding 12 hours, and based on this, it predicts a score. It gives a score and the risk of deterioration in the next 12 to 24 hours. So as you can see, in the initial stages, when the baby is well, there will be beat-to-beat variability, which gives, will give transient accelerations and decelerations on heart rate by the sympathetic and parasympathetic nervous system. And because of sepsis and dysfunction of the autonomic nervous system, the heart rate variability will be lost. It will be depressed. And then it will also have transient decelerations in the heart rate. So as you can see, at the time of clinical deterioration, the risk score has increased and so gives an early clinical sign for you to start antibiotics, do blood cultures, and even before clinical deterioration has set in.
So I think that's a very important point for the clinical point of view, that you monitor the heart rate and also give importance to decelerations or bradycardia, because if the child, otherwise the neonate doesn't have any reason to become bradycardic. So if the neonate is becoming bradycardic, you have to up your suspicion of neonatal sepsis. So I'll come to Dr. Devajit Sharma, the role and reliability of prediction models in diagnosis of sepsis, especially in low-income countries like ours.
Yeah, thank you, Dr. Rasna. As you have already mentioned in the beginning, that because of the non-specific sign and high mortality in low and middle income countries, and that to overuse of antibiotic or underuse of antibiotic, a good prediction model is very much necessary. But unfortunately, the only predictability of the prediction model is the unpredictability. There are different methods. First is clinical scores. There are lots of prediction models on clinical scores like Turner score, EM score. These are mostly basics on clinical science and very few basic laboratory findings. For example, Turner score, they've taken 12 different parameters, including the temperature instability, skin discoloration, peripheral sign, metabolic acidosis, total count, IT ratio, all this count, 12 signs, and if it is more than 10, they say the high chance of out of total score, high chance of neonatal sepsis. But the prediction of the specificity and sensitivity of all this clinical score is unfortunately very low. Statistical analysis, the number 2 method, statistical analysis, basically it depends on maternal risk factors, that is PROM and fever, the risk factors of the baby, that is low birth weight and preterm, and also laboratory tests. statistical analysis has relatively moderate predictability in compared to clinical scores. And machine learning, in another question you were asking in the last, I will discuss lots on machine learning. Machine learning basically depends on the data, what you have given the baby's data and all this. After the analyzing, this machine learning I'll discuss later more, but here what I want to say is that machine learning apparently has very good AUC, area under curve is 0.8 to 0.9. That is, this predictability is very good. But what so far we have seen that is more good in research setting and not in clinical setting, especially in low and middle income countries, because most of the data are from the Western countries. In India and developing countries, we hardly have any electronics record of the data sheets. So our data are always post. So we are not yet in the position to rely on machine learning. So overall, it is promising, but reliability remains variable. Often perform well-controlled research setting, but poorly in different hospitals and in different settings. Can be used as guidance. It can help us, but it cannot replace the blood culture. So please next set. And out of all, so it can help us, but it cannot. We cannot use it to diagnose neonatal sepsis. Thank you.
Correct. So I think this is a very important point which Dr. Devajit has brought out, that if you need prediction models and machine learning to help you, then we need to feed our own data. And I don't think we have reached that stage where neonatal sepsis, we have had added enough data into the machine, because the computer will only know what you have fed it. So I agree with him that it is only in a research setting probably can be used and does not have much clinical importance currently. Now, Ruchira, are there any point of care? Now you know that we're still depending on some clinical parameters, machines are not reliable. So are there any point of care tests which you can tell the audience that when they look at that, they can say that, okay, my baby has sepsis?
Yeah, definitely. First, after doing clinical suspicion, some sepsis screen, their predictability and all, we know their sensitivity and specificity issue. Then comes point of care test. Now there are a couple of them like CRP, procalcitonin, interleukin 6, and presepsin, lactate, and PCR based model tests. Every test has got its pros and its cons. If I talk about CRP is a one acute phase reactant. It is little late to rise, say after 8 to 12 hours. And and the peak reaches 48 hours approximately, 24-48 hours. So that is how it rises slowly. It comes little late during the process of infection. When I talk about procalcitonin, yes, it rises early. This is a pros, but the con says that there can be a physiological rise in procalcitonin in first 48 hours. And there are reasons well specified for that. Why does it increase? Then coming to interleukin 6, yes, it is a cytokine marker, which shows that there is a cytokine release have happened. So now this starts very early. Its rise starts very early, within 2 to 3 hours, 2 to 4 hours. The process, early diagnosis, but the cons is it lasts very short. It's a short-lived, and it declined very fast as well. So if we do it during the later part of sepsis, it won't help us. Coming to presepsin, again, it is a monocyte activation indicator, which again rises very fast, between 2 to 3 hours, sometime even earlier than interleukin 6. But its life is also short-lived, and it also declines fast. Then comes blood lactate level. It is definite marker of sepsis. The issue is, it's more important there are other reasons of increase in lactate, not only sepsis. Other than that, it is a very good marker for assessing severity or monitoring of the treatment. Coming to PCR based test, yes, it is a point of care test. We can try to find out even within 1 to 6 hours. But again, if you look at the specificity and sensitivity, it's also good, but depend what kind of machine is used, where, do we have that kind of availability of these tests? When I talk about interleukin 6, precepts and PCR-based tests, their availability is an issue. For PCR, which kind of PCR are you doing? This again is a important aspect when we talk about this. So, coming on to assessing all these things, what I feel, clinical picture, sepsis screen, along with interleukin 6 vis-a-vis pre-sepsin, these are a couple of markers which can definitely help. CRP is for monitoring of the treatment. Again, same is for lactate. If lactate is worsening, it means the baby is going into more severe mode. So these are a couple of things which I want to tell you.
Ultimately, what I understand from what you've described is that we are still relying on CRP and probably procalcitonin and lactate. But you have to take the key role which has been written here into mind and then monitor these patients.
Absolutely. And as per timeline.
Yeah, okay. So we'll go to the next question to again Ajay. Are there any tests that can be done on the mother to predict the risk of neonatal sepsis?
So as we have already discussed, the early onset sepsis, the most likely organism is likely to be from the mother only. So, but there are no single maternal tests that can reliably predict the causative organism in the neonatal sepsis. In the West, group B streptococcus screening is very common. They do vaginal rectal swab at 35 to 37 weeks to identify streptococcus, and if it comes positive, it indicates, it's an indication for the intrapartum antibiotic prophylaxis, because this organism can be transferred to the baby, and it helps in reducing the neonatal sepsis risk significantly. And maternal urine culture during pregnancy, if there is any bacteria, this may be associated with higher neonatal infection risk. Otherwise, intrapartum maternal infection markers like maternal fever, because it gives indication that we need to evaluate the neonate for sepsis, and it may be often linked to chorioamnionitis. And maternal tests like CRP and TLC, they have limited clinical utility for sepsis in the newborn. But the emerging and research biomarkers, as already discussed by Dr. Ruchira, also like procalcitonin, IL-6 and molecular diagnostics, they are coming up, but they do not have a definite role right now. So, next slide please. So clinical risk factors often are more important than the tests. Prolonged rupture of membranes, preterm labor, maternal fever, foul-smelling liquor, because it may indicate chorioamnionitis. And if there is a history of invasive group B streptococcus disease in the earlier pregnancies, these are more important risk factors. And this gives clinically, there may be some indication for the neonatal sepsis screening. So the only widely accepted screening test is GBS screening in the West, but the modern approaches, they combine maternal fever, GBS status, duration of rupture of membranes, and the gestational age.
So I think these things were there before also and they haven't changed. There have been studies where people have tried looking at placenta and cord frozen sections to predict, but I think those are practically not applicable in the clinical setting. So I think for maternal...
GBS practically does not exist.
Not in India, yeah. So we said West before.
And we will be talking about the GBS calculator, the EOS calculator a little bit later.
Yeah, yeah, okay. So that's why I'll come to you again. What is the role of target profiles for diagnosis of neonatal sepsis?
So as we know, sepsis presents with non-specific clinical signs, and blood culture is the gold standard, but it is low and insensitive. So we need a target profile which can predict the risk of sepsis, has high sensitivity, and detect an etiological agent. But what we are left with is still a sepsis screen. So that's available now, and it's still commonly used. So the sepsis screen comprises of the total leukocyte count if less than 5,000, or the absolute neutrophil counts are low for age if the immature to total neutrophil ratio is more than 0.2, if the micro CASR is elevated or the CRP is elevated. So this target profile, the sepsis screen is positive if more than 2 parameters are abnormal. So in a symptomatic neonate with a positive profile, it suggests to start empiric antibiotic therapy immediately, and it's got more of a negative predictive value. So if the sepsis profile is negative, especially the serial CRPs are negative, antibiotics can be stopped early by 36 to 48 hours. And so we know it's not without limitations. So no single marker is sufficiently sensitive or specific. As Dr. Ruchira earlier discussed, CRP rises late by 12 to 24 hours. And these hematological indices have wide variation of normal in neonates. And they have good negative predictive value, but poor positive predictive value. So this septic profile is to be used in conjunction with clinical judgment and not a standalone diagnostic test.
Right. So, and there could be some false positives also, no, for sepsis screen, like if you have a meconium aspiration, asphyxia.
And even if suppose your microbiology lab is good, where people can see, then sometimes toxic granules also a good
Right.
microbiologist find out in the peripheral skin. Sometimes that also happens. So
Devidita, you want to add something?
Oh, no, this is sufficient. Next question I will
Yeah,
get.
next question
Yeah,
is
I'll
yours,
take
so
it.
you can add now. How can one utilize the CBC? Because we talk of sepsis screen, very specific parameters.
Yes, that's-
What
yeah.
about the rest of the parameters in the complete blood count?
Yeah. Advantage of the CBC is it is easily, you can get it easily in almost every hospitals and very quick turnaround time, and most cases we use it is maybe reliable. But if we take sufficient precaution, important is that no single blood cell index has been sensitive enough to exclude the confirmed sepsis other than blood culture. CBC, when you do CBC, it's a complete blood count, that is very important. If you do it immediately after birth and high leukocytosis, usually indicate birth stress, maternal hypertension, and antenatal steroid use rather than the clinical infection. Many people you used to see in many NICUs, they immediately do the count and high count as a start antibiotic. It is not leukocytosis at immediately after, very unlikely to be sepsis. So recommended timing is the 6 to 12 hours after birth. If we do it 6 to 12 hours after, it reflects more, especially leukopenia, more early onset sepsis than doing immediately after that. Leukopenia with high percentage of immature to white blood cells were associated with early onset sepsis. IT ratio is single most, if we important, most only important is IT ratio. It is very high predictive value. IT ratio is more than 2, suggests sepsis. But if it is more than 0.4, then it is very high probability of sepsis.
Correct.
Late onset sepsis associated with leukopenia or maybe even leukocytosis with high ANC. If leukocytosis with high ANC and high IT ratio, then only we give importance to the leukocytosis, not with other way. Next slide, please. Just quickly, quick look. The total parameter, if you see total leukocyte count, sensitivity low, specificity low, but is very poor standalone marker alone. ANC is moderate sensitivity, moderate specificity, better, one low. IT ratio, as we have already discussed, if it is more than 0.2, that is good chance of sepsis, but it is more than 0.4, very high chance of sepsis. So if you take a single parameter of sepsis, IT ratio always. And platelet count, it is low early, in sensitivity very low, specificity moderate, clinical very late, but we can use it to see the seriousness and also for the prognostic purpose. Other parameters like granular toxic granules, RDW, racial indices, these studies are going on, but not yet we can take just one parameter to diagnose all this. Overall, CBC is very easily accessible. We can use it intelligently, but if we don't apply enough intelligence, it can be used as well. Thank you.
So I think it's, yeah.
Dr. Rashna? So when we have 2 or more markers positive, that has better predictive value, almost up to 90 to 100%. And along with that, important is that, okay, that we'll discuss later.
Yeah. So I think it is very important that when you do the timing, I think that's a very important point which has come out, that the timing of the complete blood count. So do it after 6 hours. and then look at all the parameters. And I think some of these parameters, like the platelets, can be used for monitoring the severity of the disease. So Ruchira, we have again a controversy. Now you showed both PCR procalcitonin more higher up in the chart, so and blood culture. So which one is the best?
See, Preeti has already told blood culture is gold standard, so there's no doubt about it. But its sensitivity and all these issues we already have discussed. When we talk about PCT, the molecular-based test, then the advantage is it detects bacterial DNA directly, and even the slightest can be picked up depending upon what type of PCR we are doing. Advantage of point-of-care test, if we talk about, is like we get rapid results, bedside test availability, and this will help in making early antibiotic decision. It will definitely help that. But there are limitations too. Now, limitation is no single test is definitive, as we discussed. False positive and false negative results chances are definitely there. And so what is gold standard? Again, I feel is clinical judgment, sepsis screen, and blood culture.
So blood culture is
because
a must.
blood culture will take some time to come positive.
But we have to do it. Wait for the results. Till then, do the sepsis screen.
Absolutely.
And within 36 to 48 hours, you will get something.
Absolutely.
Yeah.
Something we will get, some idea.
Okay. So this, I think you have already touched the limitations.
Yeah.
Would you like to again say something?
So just I want to say the key home message is that point of care test, it supports early decision making, but diagnosis ultimately depends, again I am repeating, on clinical picture, the clinical judgment and blood culture. They are the most important one, but definitely the sepsis screen will help you or give you some
at least to monitor.
Monitoring
Right.
and early decision making of starting.
Early decision making both for starting as well as for stopping, right?
Stopping as well. De-escalation of therapy also we can do. The moment we get if 2 sepsis screens are negative, then we can easily rule out sepsis.
Okay, thank you.
But nowadays, one culture usually take those 36 to 48 hours, says in nowadays in modern backtrack and all.
Yeah.
In neonatal spaces, if it is goes something in within 24 hours, very high chance of it will come positive. If it is not going anything in 24 hours, very unlikely it will come out positive. So in 24 hours, we know something at least.
Depend upon what is the nature of organism, whether it is a fast-growing organism or not.
Okay. So because they are mostly gram negative, they grow early. Okay. So Ajay, next question is for you. Any newer molecular tests that you may have read which may help?
So the main aim, because the normal sepsis screening, which includes the blood culture and CBC, etc., they may help in starting the empirical antibiotics. But our main aim is to reduce the antimicrobial resistance, do a targeted therapy, to do escalation, whether we need to escalate or de-escalate the therapy, and use whatever antibiotic is best suited. For this, now the molecular diagnostic tests are being available. They may use multiplex PCR or RNA PCR, but these should be done in conjunction with the blood culture, because blood culture will give the antibiotic sensitivity report also, which most of the molecular diagnostics are not able to give, but with the newer diagnostic methods, it may be possible. So it helps in rapid pathogen detection, even in culture negative sepsis. And it helps in giving a early targeted therapy, or even helps in stopping the therapy. If the culture is negative and even the molecular tests are negative, so one may consider, depending upon the clinical condition, stopping the antibiotic therapy as early as possible. So consider a molecular test if the maternal antibiotics have been used and there is a high risk exposure and uncertain clinical picture. And as I have already told, it supports the diagnosis of sepsis and targeted therapy, and but we still need correlation with the blood culture and the clinical condition of the patient.
And probably these molecular tests still are not available everywhere to be done.
But now, with the advent of coming down of the cost, and now their multiplex is little expensive, but now they're like CB-NAT, which is used for tuberculosis. The cost is coming down. So similarly, for other targeted organisms, the cost may come down.
Correct. So I'll come to Preeti. What is your comment on the sepsis calculator? Do you think we should use it? Not? Is it useful?
Okay. The sepsis calculator or the Kaiser Permanent Sepsis Calculator is an interactive tool which calculates the risk of neonatal early onset sepsis in asymptomatic infants more than 35 weeks gestation based on maternal risk factors and the infant's clinical presentation after birth. So it has been shown to reduce reduce antibiotic treatment by 74% among late preterm and term-born infants, and reduced lab tests, blood cultures, admission to the neonatal unit, reduced healthcare costs with no increase in mortality and readmissions compared to traditional methods. But it's not without caveats. If you look at all the variables which have been taken into consideration in making the sepsis calculator, which was developed and validated in high-income countries. So the incidence of early onset sepsis in India is not known and varies by region and institutions also. And gestational age, it's limited to infants more than 35 weeks of age, and maternal GBS status. So GBS is an uncommon cause of early onset sepsis in our country. And maternal GBS colonization status, we never do screening. So it's really not applicable in India.
Any of the other panelists, do you have a comment on this neonatal sepsis calculator?
Just 1 minute more. So we've also got limited data from low and middle income countries. And so the NNF does not recommend using the sepsis calculator in its clinical practice guideline. Even the NICE from UK recommends it only as a research or audit tool.
I wanted to say that only. In clinical practice, it's very difficult in day-to-day practice to follow this, especially it's made for high-income countries. So for us, I mean, yeah.
So the problem with
have
this
to see
neonatal sepsis calculator, I think one of the parameters is maternal GBS status. So that will be anyway negative in our, So I think when you are talking of a neonatal sepsis calculator, then it's something we have to develop one for ourselves with some of these parameters put differently, right? Okay. So we'll go to Dr. Devajit Sharma. Again, I'm asking him all the tough questions. What about machine learning, and now we have ChatGPT and all these other AI tools? Do you think it can predict neonatal sepsis?
Yeah,
the resident may say, I will just put it in ChatGPT and tell you yes or
but
no.
Unfortunately, I have to use my actual intelligence to answer on the artificial intelligence. Yeah. Yes. It's a promising, as I said, that prediction models are very unpredictable. That is the problem, but we need it. When we need it, machine learning is a traditional tools have very low sensitivity, as we have already discussed in my first questions. Cursors are specific but slow and low sensitivity. Machine learning addresses all this by identifying hidden pattern in complex multidimensional data. That is the important, because in all the traditional model, we always follow the complete things we already know. But in machine, after feeding all the data, we can find some hidden point, hidden learning, which we usually not detect, is not in all the clinical scores. That machine can predict, because we have all the data that we have already feed in the machines. It all depends. Actually, machine learning can again, and artificial reasoning, we can use there as supervised learning. Supervised learning is all about electronics record. We have already we already knows the risk factors and maternal risk factors, baby's risk factor, maternal history, baby's history, prenatal, antenatal history, and also finding everything we have already in the machines, and then they find out, and then they, if we put the baby's record, then they can say the probability of the sepsis. In deep learning, we go one step beyond. Along with that, all this, what she has told on the first answer, that ACRO and heart rate changing, temperature, and all the vitals monitoring. It is already, we feed everything on the machine, and then when we find out if any abnormality they can predict. That is deep learning. It is good for continuous neonatal monitoring, because this machine feed in the monitor and monitor anything abnormal, any heart rate is going down below certain level, and it can immediately alarm us and to ask us to look carefully. Unsupervised learning, it is the little different. We put the maternal record here and then previous record and then also treatment what we are giving. All this analyzed and then machine can check what to suspect. So overall, early prediction models, real-time monitoring system, this risk stratification is very high. It can help us in decision support system, but it all depends on what data we are feeding in. And you see, the AI in prediction of neonatal screening, we need more in developing countries because we have more high mortality rate, high neonatal sepsis. But unfortunately, data from our countries, for developing countries, still very low. So whatever data already feedden in the machines is all Western data.
Correct.
So as data, if we see the whatever already feed, area under curve, what is 0.8 to 0.9. That means if machine is saying there's very high probability of the sepsis. But point is that it is all in research nowadays and practically in hospital setting, especially in Indian hospital setting, government hospital setting. We are not yet able to use it because of this, because our data are not fed.
Correct.
Thank
So
you.
I think very important point that most of our data is not there in the system. So if you use this, you'll be doing it with using the Western data which has been fed into the machine. So we'll come to the last part of our discussion. We have around 10 minutes. Choice of antibiotics for early onset sepsis. What are the current guidelines, Ruchira?
So this is as per WHO, where they say that the first line, if there is low risk, then start with ampicillin and gentamicin. If there is a moderate risk, think of ampicillin and amikacin. If the patient is high risk, coming from some other center, referral center, then use meropenem and vancomycin. And there are definite reasons for choosing it. However, this is what
So this is, I think, based on whatever we have collected the data of cultures across our units in the low income countries.
This is what WHO is recommending on the basis of their collection. What we come to the practical approach. Now in practice, we don't see ampicillin has got advantage of covering listeria. We don't see listeria. I have not seen listeria till
correct.
now. So this is one thing. So what I feel, our teachers sitting in this row, Dr. Bala sir, Dr. Kasi, Dr. Chitkara, Dr. Kukreja, Dr. Abhay, all these have taught us. Whatever decision I have made it like this, okay, whatever is recommended by the body, we have to write it down. But what actually the practical is to have the own antibiogram.
Correct.
And then on the basis of that, one should look for the
Empiric
choice, empirical therapy, which is to be given. And as we have discussed, there is no demarcation between early onset vis-a-vis late onset sepsis anymore existing. So we should think of even the organism which we earlier used to think like drug resistant, gram-negative, ESBs and all. Now they are existing in the early onset sepsis too. So I feel that the best choice will be to have antibiogram, choose the empiric therapy as per the antibiogram of that area, and then once the culture is there, depending upon the response, the culture and the other parameters, we can think of de-escalating the treatment.
Right.
Or as per the sensitivity, escalating the treatment. That is what is the final take, I feel so.
Okay. So again to Ajay, what about late onset sepsis? Ruchira says the organisms are the same. So what do we do?
So as she has already told, best is having an antibiogram because that will give us the most likely organism as well as the most best suited antibiotics. The first line empirical antibiotic therapy in a stable patient may be Praslin tazobactam with amikacin. Because it covers most of the gram-negative organisms, and amikacin helps in improving the coverage for Enterobacteriaceae also. In resource-limited or low-resistance settings, simply having cefotaxime with amikacin will be sufficient. But in high-risk severe sepsis or NICU with high ESBL rates, then meropenem or if the meningitis is suspected, vancomycin may be the antibiotics of choice, because it helps in covering the shock, meningitis, ventilated neonates, and sometimes the neonate may have been referred from outside and may have received certain antibiotics. So it helps. In cases of suspected fungal sepsis, then one may be required to add fluconazole or amphotericin B. And if there is no response to antibiotics after 48 to 72 hours, thrombocytopenia is there, prolonged TPN is there, then antifungals are again needed. And because with the advent of molecular diagnostics, we may be able to provide a targeted therapy at an early stage.
Fine. So I think this is very clear that in the late sepsis, will be maybe probably add antifungals and cover for staph also. So this is the practical approach which he has already said. I'll go to the next question. Any role of probiotics? We have 5 minutes now.
Yeah, all the fancy questions are
Yes, fancy questions are for you.
Probiotics are promising definitely, but what we are using for all these probiotics, they are claiming for all the disease starting from the neonatal sepsis to Alzheimer's disease. Yes, promising, but we are using it way ahead of the disease. Problem is that, yeah. Why it is promising? It can, in theoretically cause blood microbial modulations. It enhancement mucosal barrier. It reduces the pathogen colonization. What are the pathogenic bacteria in the E. coli and all? It is reduce the numbers and it helps. It changes to some helpful bacteria like bifidobacteria, and it also increases our immunogenicity by increased through IgA modulation. But problem is that all any strains of probiotic won't help. So what are the strains? It might help is it is only 4 strains: Bifidobacterium brevi, Bifidobacterium infantum, and Nemnosus GG, and also combination of all. It may help. Multiple studies done on this subject, and our meta-analysis shows relatively convincingly it might reduce late onset sepsis, not early onset sepsis. It might reduce neonatal NEC, and it might definitely reduce mortality. But problem is that there is a quality of strain what we are using, especially in developing countries. It might help prevention, but problem is in quality and also contamination that we cannot grant it in most of the low and middle income countries. So who recommends? Who says that recommends probiotic for preterm in less than 32 weeks where quality assured products are available? If quality is assured, then who says you can use it below 32 weeks for prevention? American Academy of more cautious. American Academy of Pediatrics saying concern about product quality and safety, not recommended universally. Immediately, Asfagan also saying that if quality is assured, then you can use below 3 months. So for prophylaxis, we can definitely use it if quality is assured, and if proper stain is used, and if you are storing in proper temperature. But problem is that there are rarely cases reported with the septicemia, especially in extreme preterm babies and immunocompromised. This stain even develops septicemia, reports are there. But for treatment purpose, there is no single evidence, should not and cut replace antibiotic. Role remains adjunctive and experimental, rare cases of probiotic associated sepsis. So, if you wish in proper stain, you can use along with the antibiotic for treatment, but it cannot replace antibiotic, and for prophylaxis, definitely it is promising. Thank you.
So the last question, I think, for Ruchira. What about IVIG, then pentaglobin, blood products?
So, talking about IVIG, if you want one single line, then as per Cochrane review, as per Croharty, as per any of the, lot of studies, they've said that there is no role of IVIG in the management of neonatal sepsis, number one. Number two, there was a thought going on that in the preterm it might have helped because they have low immunity, low IG levels, and when this is given, it helps in boosting immunity. However, generally, there is no role. Coming to blood products, yes, if the hemoglobin is low, that again depends upon the level of sepsis, severe sepsis, moderate, and like that. Then depending upon a definite cutoff point is there for each one, that hemoglobin level you have to give blood products, especially in shock. Coming to platelets. Again, low platelet count, bleeding manifestation, we need to give. Fresh frozen plasma, if PTINR is deranged, then we definitely consider of giving transfusing plasma.
Okay. So thank you very much. We are on time. We have 1 minute left, and I'll just summarize what we have discussed in the last 45 minutes. So sepsis screen, I think, still remains the clinically useful marker in most places in our settings, along with what the Preeti has shown us, the physio markers, which is a very useful clinical tool for monitoring and early detection of sepsis. Algorithms, machine learning, and prediction models are tried, still in the research stage, and I think they are not perfect as yet. We'll have to wait for some time. Microbiological diagnosis with added molecular test can help get an early diagnosis and guide the therapy, both for starting as well as for de-escalating. And antibiotics are best based on local culture sensitivity patterns, and there is no role of IVIG as such. So thank you very much, and I thank all my panelists for a very nice discussion. Thank you.
Thank you, Dr. Rachna Das. May I request Dr. Abhay Shah to kindly hand over the mementos to our panelists. Please, panelists, follow. So our next panel discussion is problem in the diagnosis and management of community-acquired pneumonias. Though we have so many vaccines, 7-valent, 10-valent, 13-valent, 14-valent, but pneumonia is always a problem. So I invite the moderator, Dr. Shyam Kukreja, and the panelists are Dr. A.J. Chitkara. Sir, come. Mrityunjoy Das, Yognesh Popot, and Subhashish Roy. Please take your seat.
Good morning, and good morning to my panelists also. So we have a very senior panel, and I will encourage discussion and difference of opinion also. So I'm not interested to give a clear-cut, what you practice in your day-to-day practice, I want that. Anyway, our topic is community-acquired pneumonia. And what is community-acquired pneumonia? It is basically infection of the lung parenchyma, which is occurring in a community, in a children up to the age of 18 years. This is what we are going to discuss. And I'll start straight away say it is one of the very common cause of morbidity and mortality in children. Something like 12 to 14% of mortality under 5 is contributed by pneumonias. And this is a topic we should discuss in detail. And I'll be starting my discussion with very simple scenarios, what we see in our clinical practice, and gradually built up to cases which are a little complex and which test us in our day-to-day practice. So this is a simple case. You are sitting in the OPD. This is a 2-year-old child. He's got fever, cough. You find a respiratory rate of 52, there's no distress, and you have a pulse oximeter in your clinic, and it is 97%. Now, there are several questions. If you see the respiratory rate, should I treat it as pneumonia? In this case, according to WHO, I must give antibiotics. If there's a difference of opinion, some will say, we don't want to give antibiotics, I want to wait, I like to find out. If antibiotic, which one will you choose? And what is a WHO recommendation? I start from Subhashish.
Good morning, everybody.
Good morning.
So which question should I take? All the questions? Sir, which question you expect me? All the questions?
Actually, there's an echo, I can't hear. Can I have a...
Subhashish, you hold the mic little away from the...
Okay, so a child who is having of age of 2 years, cough, respiratory rate of 52, there is no distress, saturation is well maintained, and I presume the child is not toxic as well, then I can tell you this is a child who is having a lung infection. It can be upper respiratory, it can be lower respiratory.
Okay.
Without knowing the other features, like whether there is coryza, whether there is red eye, whether there is any associated diarrhea, I will not straight away start antibiotic. I will not label it as pneumonia. And I will treat as pneumonia if I am staying in a resource poor setting where I don't have anything, any investigation possible, then I will treat it as pneumonia. Otherwise, a child who is having tachypnea,
We like to do.
right at this moment, I will not do any investigation.
Okay. Dr. Popat, any difference of opinion? Dr. Subhashi says, I want to wait. क्या कहेंगे पेशेंट को 6 घंटे बाद आके दिखाना?
As sir has said, as per the WHO classification, this could be labeled as a case of a pneumonia. But WHO classification is mainly for the health workers in the periphery where there is limited resources. So if you are sitting in a clinic where you have an opportunity to so that the patient is there for the follow-up next day or next day, then definitely you can wait. There is no hurry to start any antibiotic or in this case.
तो देखो ऐसा है कि WHO criteria says if there is a cough or breathing difficulty plus fast breathing.
So WHO definitely says it is pneumonia.
Let them tell the audience. And if there is a 60, 50, 40 plus cough, it is pneumonia. 60 means if it is less than 2 months and the respiratory rate is more than 60, 2 months to 1 year, if the rate is more than 50, and if it is the child is between 1 to 5, more than 40. So this is tachypnea, and if there is a tachypnea plus cough, it is pneumonia.
It is pneumonia.
So kar den treat.
So it is for the clinic health workers, not for individual doctors who are sitting in their OPD in a reasonably good setup, even tier 2 cities. So we are not in a hurry to start any antibiotic. If we are sure the patient will come for the follow-up next day or whenever you want. So we can ask the child to come for the follow-up next day.
Then what could be the cause of Dr. Mrutyunjay, the cause of this fast breathing?
Actually, WHO
If it is not pneumonia, let's put it.
WHO defines pneumonia correct, that is 60, 50, 40 plus cough. But as a clinician, this is meant for the Asa Anganwadi worker in the IMNCI guideline, according to the IMNCI guideline. But when the child is coming to us and we are clinician, pediatrician sitting over here, then we should judge whether the etiology is bacterial or something else. Because this child is having a very short duration cough, very short duration of fever, saturation is maintained, child is not looking sick. So we should wait for 48 hours before giving antibiotics, try to give some supportive management with some paracetamol or some soothing agents. Then we should wait for 48 hours, see the child condition, because if you do X-ray right now, you will not get any finding. Because though you are clinician sitting in a tertiary care, we won't get, because X-ray development will take at least 12 to 14 hours to have some pictures.
Dr. Chitkara, do you do X-ray in community acquired pneumonia routinely?
No, in fact, I have a problem with the WHO definition only.
No, we will come to that.
Do
you recommend?
No,
Do
so
you
why
recommend?
X-ray? With an X-ray chest, see, if it is a fever, cough, tachypnea, plus added chest signs, I would probably seek an X-ray chest, where we practice, middle or tertiary care, the places. So my context was only that for a clinician, please suspect pneumonia, fever, cough, tachypnea, plus chest signs with SpO2, which is almost a vital sign, radiological documentation, and also an associated elevated CRP. That makes a high precision definition of pneumonia with probably a low sensitivity in the community, but high sensitivity and a very high specificity in your clinics or
Chitkara, हम तो नहीं करते इतने सारे investigation इतने
हम
patient
नहीं करते हैं, लेकिन अगर chest signs ऐड कर दोगे तो मैं clinic में unless there are chest signs in a patient with fever, cough, tachypnea, and with these normal saturations, we don't get an immediate X-ray chest.
See the WHO definition, is giving you cough and respiratory rate. I have got fever also, so it is little more specific. Is it pneumonia or not? Or if it is not pneumonia, what could be the causes?
There are so many things which can cause tachypnea in a child. Simple fever will have some respiratory rates increasing, number one. Number two, small young children nasal block. Number three, dehydration. They will all lead to some tachypnea. So tachypnea is just not a hallmark unless taken as a part of the complete spectrum. And if you add chest signs, you are more specific as far as clinicians are.
Okay.
So, just one point.
Yes, yes, please go ahead.
The chest signs are very important here. The chest signs are very important here because if the child is having bilateral wheeze or rhonchi, then it can be a viral RTI. So no need to start antibiotic, no need to do any chest X-ray.
Okay, I summarize this case, and for this case, you have got fever, cough, saturation is okay, and this fever could be because of nasal block, it could be because of fever, it could be soon after crying, it could be because of wheezing. All these factors make the child little tachypnic, and this is a WHO definition of pneumonia. And do you use this approach of fast breathing to diagnose pneumonia? I asked this, and there is a Cherian study from Vellore. They said that it's very sensitive. Almost 90% you will pick up pneumonia, but the problem is the specificity goes down, and WHO prioritizes not missing pneumonia. They feel this is a major cause of mortality in the resource poor countries. There is a highly sensitive clinical criteria is to be required, means the case definition is so broad, just cough and tachypnea, so that the plan is not to miss any pneumonia. It accepts over treatment as a trade-off, and the benefits of saving lives, they believe, are much more, they outweigh the risk of unnecessary treatment. But in the era of antimicrobial stewardship, I think it is very, very important, where we are having a lot of resistance. I think it is very necessary that all of us in our practice do not follow what the peripheral doctor has to do, peripheral person has to do. It is for them, it is not for us. We have to follow the textbook approach, and why in well-resourced country, or I'll put it in our practice, we should not follow this. We should follow this simple textbook approach, do everything which Dr. Chitkara was telling, including auscultation, even epidemiological consideration, host characteristics, and if in doubt, only then investigate. I think otherwise, in a community acquired pneumonia, there is hardly need for any X-ray, don't expose the child to radiation. So this was one simple case to set the ground of discussion. Now we come to second case. I am taking very simple case which you see in day-to-day practice, and we are analyzing that, how people sort of approach them. This is a 2-month-old infant, low-grade fever, mild cough, cold, and decreased feeding for last 2 days. Fast breathing is noticed by the parents for last 1 or 2 days. Occasional irritability. Respiratory rate is 74, no respiratory distress, saturation is 95, and what's your diagnosis? I'll start with now Dr. Popat.
So here we have a young child, 2-month-old only. We have a fever, cough, cold, though mild. There is a breathing difficulty and irritability. Irritability could be because of the oxygen hunger also. So even there is a tachypnea. So we have a good number of differential diagnoses. Of course, pneumonia is one of them. Bronchiolitis here is another cause where there is a low fever and the minimal cough with more tachypnea. So bronchiolitis should be ruled out here. Another cause could be GERD in such a young child, where GERD should be ruled out. Hypersensitive sensitive airways following the viral infection is another cause, could be the another cause.
I think Dr. Popat, I forgot to tell, there's a family history of cough and cold in the mother also.
So viral infection in the child followed by the bronchiolitis? It is not ruled out. It is one of the DD here. I didn't say it is ruled out. It is one of the DD here. So pneumonia, bronchiolitis, hypersensitivity airways following the viral infections, GERD, this could be the differential diagnosis here.
So what's your differential diagnosis here? Bronchiolitis, number one?
Bronchiolitis definitely number one because young child.
And second?
Pneumonia could be there, post-viral hypersensitivity reactions could be there,
Okay.
GIRD could be there.
Okay. Okay, I just going to come. In this case, it could be pneumonia, it could be Walry, it could be bronchiolitis. And if you see, this common thing is they have cough, fever and tachypnea. And how do I differentiate in my busy OPD practice? It fits into this. And Dr. Murtanjay, how I in my busy OPD decide this fits into this? Because
So,
you have hardly
without-
2-3 minutes to work.
Sir, without any investigation from the history, if the child is fitting at a very low age, within the infant, 6 months below, and there is cough and fever, and you auscultate there, you got lot of bronchitis.
We have discussed that. Out of this, how will you say this is
So,
bronchiolitis? How do
first
you
is,
say
sir-
this is Walry and how you say this is pneumonia? What
Sir,
fits in there?
Because pneumonia will have crepes, sir. Bilateral crepes or unilateral crepes will be there, number one. Number two, there will be toxicity will be there. If the bacterial is there, if the toxicity will be there. And if viral, then must be some family members will be suffering. But in wheezing child, wheezing will be the most predominant manifestation, and the child will be not so sick looking, and very acute onset of exacerbation have occurred within 1 to 2 days, and with a family history of atopia or asthma. So that we will have to take the history from pneumonia and that of bronchiolitis.
Okay, if I summarize this
Sir,
case.
sir, can I add one?
Yes, sir, please go ahead. I am encouraging that.
First of all, in bronchiolitis, there will be a lot of crackles bilateral. The child will be irritable, not toxic. This is number one. Number two, pneumonia, the child will be very sick. In a 2-month-old child, the child will be very sick. But the chest signs are more or less not very much differentiating point. There is no term like Walry. We say it preschool wheeze. But first diagnosis in this child, the history we have given fits with bronchiolitis. And a child who is having a respiratory rate of 74 without any respiratory distress, you have written a line. This is
Okay.
slightly contradictory.
Okay.
Because a child who is having
So-
74 respiratory rate
so
will be
let's put it-
respiratory distress.
Shyam, in spite of the first case and WHO definition, you have still used only the WHO definition in the first slide. So therefore, all this discussion.
We have graduated to specific
Yes,
illnesses now.
so the summary of your last presentation was that for doctors it should be different. Yet you don't have a chest signs in this particular this thing. So that is why this all rigmarole of overlap
Okay. So
is
you want
coming.
chest sign in this. I think we have given bit of chest signs.
But only one line which must be
Diffuse
remembered
crackles
is
and occasional wheeze.
early infancy have a low threshold for a bacteremic illness. That must be in your mind after you go through this differential diagnosis in this patient.
Okay. In this patient there was mild wheezing was there and this was bilateral. Anyway, this was the question and we said cough, fever, tachypnea. If you differentiate, pneumonia classically as the panelist said, it is fever and there are focal signs. It could be bronchial breathing, it could be focal signs in the form of crackles. In Walry, in parenchyma, particularly in pneumonia, there are not many cough receptors. So cough is not a predominant feature to begin with. Now coming to Walry. Walry can happen at any age, but usually after the age of 4 or 5 years or 3-4 years. But in this case, it is basically the bronchi which are involved. So cough is a major factor, like in asthma. Then there can be wheezing and the children are usually older. Now if you take the host characteristics, this child is 2 months old. It fits more into bronchiolitis. In bronchiolitis, classically, their cough is minimal. The reason being because bronchioles do not have cough receptors. They immediately get clogged, being very thin in caliber. So what happens is they have a wheezing, they have a breathing difficulty, they have a feeding difficulty, and the child is okay for 3-4 days. Suddenly on the 5th day, mother says he is having breathlessness. So this is how we differentiate. If I summarize pneumonia, focal signs, high fever, no response to bronchodilators, Walry, cough, wheeze predominant, response to bronchodilators, often older child with recurrent episodes, bronchiolitis less than 2 years, wheezing, feeding difficulty, and minimal bronchodilator response. Now coming to case 3. Dr. Chitkara, you can start with. This is a 12-year-old child, presents to OPD with cough for 7 days, is quite troublesome at night, low grade fever 100-101, sore throat, not sick looking, mild malaise, active appetite is normal, and saturation is 97, diffuse crackles, both lungs, occasional wheeze. Your diagnosis. I'll go to Murtanjay. I miss, sorry.
No,
I'll go to Dr. Murtanjay. Sorry. I miss you, sorry.
So by serial number, difficult case for me. So okay, anyway. So this is a 12-year child. First of all, the age is very important for us, and the troublesome cough at night, low grade fever. So somehow it is fitting into pneumonia also and non-pneumonia also, because having non-pneumonia with some ARI-like thing, we can also get this type of picture. But there is a point in that the child is having a diffuse crackles. So diffuse crackles is something in a 12-year-old child with a cough for 7 days.
Diffuse I mean is both the lungs, but not too much. Not too much. Both the lungs, I'm sorry.
So okay.
It is
so
bilateral.
Bilateral crackles. So there
Yes,
is no
sir.
diffuse crackles.
No,
okay.
sorry, I'm sorry.
So bilateral crackles with a 12-year-old child. So my diagnosis will be a case of viral pneumonia or mycoplasma pneumonia with some type of reactive airway disease component, like
There's no past history of recurrent cough and
that is not written. So okay, that occasional wheeze is there. So might be a case of viral induced pneumonia. Or
the other part is the mother tells me, Doctor Sahab, this child is still going to the school, and even if he is little unwell, but he is able to manage to go to school.
So it typically fits into a atypical or working pneumonia like condition, mostly mycoplasma, and the age is also fitting that 12 year of age. So that is my take home diagnosis from this.
I think I think you are absolutely right. It fits into mycoplasma. If you read each and every line, it is telling you it is mycoplasma. I tell you, I summarize this like this: usually persistent cough, dry hacking, low grade fever, fatigue, headache was not there, but headache, if you ask on a leading question, they will say, Doctor, screen zyada dekhta hai. Anyway, sore throat, mild chest discomfort, not reported in this, no respiratory distress, able to continue with daily activities. And the interesting thing is, if you see mycoplasma, they tend to get admitted in your practice after day 5, day 6. They don't come to your practice sick in first 2 days, like in pyogenic bacterial infection. So this is a very classical picture of mycoplasma, and
Sir,
now
one
mycoplasma.
Sir, one more thing. One clue should have been there for any other systemic involvement, because mycoplasma doesn't settle only in respiratory. Sometimes other system might have been affected, like anemia or something like.
We'll come to that. We'll come to that.
Involvement.
We'll come to that. So, mycoplasma shows mismatch between symptoms and signs. Can you discuss this?
Yes, sir. Mycoplasma, already I have told that this is a type of working pneumonia. The child will be not so sick. Tachypnea may not be there, but there will be low grade of fever with a sore throat, cough like thing. But only important thing is that it will not settle in the respiratory system. It may involve.
So what is more, symptoms or signs?
The symptoms are more, signs won't be there anything, but crackles will be milder form.
Okay.
And the only thing, sir, there must be some anemia or joint involvement or like that of.
This was not there in this
skin rash.
patient. This was not there.
We should look for when we are suspecting any mycoplasma.
You are right, we can have extra pulmonary manifestations of mycoplasma, but it was not there in this particular patient. And why this is a mismatch? The symptoms can be more than signs. Classically, symptoms are worse than signs because the infection is mainly interstitial, not a dense alveolar sort of a consolidation. And there is a bronchial inflammation which is causing a lot of irritations, and cough becomes predominant. There is less exudate produced in this, and that is the reason the auscultatory findings are lesser. But there have been reports of occasional patient where the signs are more than the symptoms, but classically symptoms are more than the signs. Now we come to another question. Dr. Chitkara, you can take this. Mycoplasma shows clinico-radiological mismatch.
So the patient really doesn't have much symptom, like this case which was presented, almost a happy child. Routine activities all being done except for a troublesome prolonged cough. Started with something like an influenza, So maybe something like a prolonged influenza illness with cough as a prominent symptom, and when the doctor examined, there were bilateral crackles as well as a wheeze. So now, if you get an X-ray done in these child, either you get, there are 2 or 3 very typical. Like he said, interstitial, so you typically described as a reticulonodular pattern, which would also be seen in a viral pneumonias. But because most of the viral infection will not be so prolonged, either will they start getting very sick. So this is something where, or sometimes the X-ray may be bad and the child doesn't have much symptoms and signs. That is why the name walking pneumonia came into being. But for us it is only, there is a mismatch, means either more radiological shadows than the clinical presentation, or a significant clinical presentation with just a reticulonodular X-ray chest or a clinico-radiological mismatch, and very suggestive of a mycoplasma.
I think classically in mycoplasma pneumonia, the X-ray is more sicker than the child. And if you see and look at the X-rays, sometimes you will be threatened. And the child doesn't look so sick to me, and the X-rays look very bad. So this is a very classical pattern of mycoplasma pneumonia, patchy infiltrates, bilateral, patchy, diffuse infiltrates, almost something like reticular interstitial pattern. It's in the bilateral and it's usually in the lower zones. Just give you one example.
One more thing.
I'm coming to that. Yes, please.
Traditionally, the mycoplasma pneumonia is known as walking pneumonia, but of late, since last 4-5 years, we had seen the change in the pattern. Now it is almost not commonly seen as a walking pneumonia. It also presents with severe symptoms and many of time with the severe complications also. So that should be kept in mind in the recent time.
You're absolutely right. Some cases can be very sick and they get admitted with us, don't respond to treatment also. Anyway, and I think you're right. Mostly the illness is after the age of 5 years. And see this child who got admitted with us recently, and this is a child who didn't respond to our treatment of beta-lactam antibiotics, and it turned out to be mycoplasma and responded very well to doxycycline. Now see this, a child who had day 7 had unilateral pneumonia and day 12 became bilateral pneumonia. This is again mycoplasma pneumonia. So what are the different presentations of mycoplasma infection? Dr. Murtanjay, you wanted to tell, you can tell now.
The most important, because I have seen in my OPD, not in my OPD, in my practice, I have seen around 10 to 12 recent past within 2 months. They mostly presented with immune-mediated hemolytic anemia, like one. We could not diagnose this, why this anemia is 7, hemoglobin of 7 of a child of 12 years. So that is the reason one of the important information. Number 2, joint involvement. They usually come with bilateral arthralgia, knee joint pain. Number 3, they usually present with some type of chest pain. That is irrespective, that is not fitting into the pneumonia. So chest pain and coming out to a pericarditis in the echocardiography we have done. And sometimes renal involvement in the form of little bit of raised UPCR, urine protein to creatinine ratio in the form of 0.5 to 0.6, little bit of renal involvement. And sir, lastly, finally, we have some type of patient with MI, only one patient I got, that is mycoplasma induced rash and mucositis. That is one. So these are the different varied presentation, but multi-system involvement is usually there in case of mycoplasma.
It almost involves all systems, including the CNS also. Encephalitis and mycoplasma meningitis is also known. It involves lung, apart from lung, liver and the kidney also.
Because it shares a lot of antigens with the host.
But I don't think one should blow up extra pulmonary associations with mycoplasma more. In general, most of the mycoplasmas would present only as a respiratory. There may be subtle signs which can, like very well said, all organs of the body can be affected. But this kind of a presentation would occur only in 5 to 10% of the mycoplasma.
So it is rare extrapulmonary presentations, as you have said, but in the pulmonary presentation, recently you have seen lot of pleural effusion. Mycoplasma is lung infection associated with pleural effusion, which earlier was thought of uncommon, but presently we are getting lobar consolidation as well as pleural effusion.
And if you subject this pleural effusion to analysis by molecular diagnosis, Even the mycoplasma comes.
Yes, you can get mycoplasma by PCR in the pleural fluids.
Okay, this is what Dr. Chitkara shared in one of the presentations, and you can see there can be respiratory, you know that, extrapulmonary, there can be encephalitis, aseptic meningitis. That's why many of the protocols have doxycycline upfront if you have a child with AES. Dermatological, yes, it could be MIRM, that is mycoplasma induced rash with the mucositis. So you can see second last picture in that category. In hematological, we have seen hemolytic anemias with mycoplasma, thrombocytopenia, aplastic anemia, musculoskeletal arthritis. So how to confirm the diagnosis? Dr. Chitkara.
So there are two modalities which are available to you, and both together should be ideally positive to give you almost 88% specificity. One, PCR. If you have respiratory passive PCRs and you pick up mycoplasma. Two, you also document an increase in serology or a positive serology. PCR you can pick up in the first week. In the second week, serology, which would almost be 3-folds or 4-folds of the original. So two together, your probability is about 88%. One alone may be less than 50%. And even with both, plus remember clinical correlation, then probably you would increase this 88% diagnostics to more. So more the merrier. There is no 100% confirmation of mycoplasma.
So mainly by PCR and
PCR, serology as correlated with the clinical presentation.
Anything else you would like to add?
No, nothing, but it has been traditionally found throat swab is a better sample than nasopharyngeal aspirate in cases of mycoplasma. And of course, if there is any pleural fluid, you can take PCR is a very good modality of.
Okay, if there is a pleural effusion. Okay. And I think if I summarize the whole thing, in my practice, I believe in non-responsive pneumonia to beta-lactam, it raises antennas and you start thinking in terms of mycoplasma. That's the number one clue. And CBC could be anything, normal, low or high. In peripheral smear, we have seen Rolex formation. For example, in mycoplasma, if the WBC coalesce and I think Rolex is RBC coalesce. In case of scrub typhus, thrombocytopenia can occur, which is false because your platelets get coalesced. Now CRP could be normal or elevated. Cold agglutinin, although we don't do today, but I tell you, I was in Kalavati hospital, we used to do in our residency because there was nothing like other investigations available. So what we used to do was we take equal amount of sodium citrate, add equal amount of blood and then sort of just stir it and put it in ice, and if the clots used to agglutination used to form, you could see with that clots in the ice. If you put it in the ice, within few minutes clots used to form, and you take out and come to room temperature, it will disappear. So this was a very important test we used to do, but I think now we have forgotten. PCR in nasopharyngeal swab, Dr. Chitkara was telling you, sensitivity 80 to 100%, but remains positive for 7 to 8 weeks. So also positive in some asymptomatics. PCR, pleura and ball is very specific. IgM mycoplasma becomes positive after 6 to 10 days. We had a case where we diagnosed because the IgM to begin with was negative and after 7 days it became positive. It's a very confirmatory test, sort of conversion to positivity. And other thing is, I had a case where, as Dr. Murtanjay was telling you, the hemoglobin fell during the admission course and then we wanted to give blood transfusions. We sent the blood to the blood bank and the question came, sir, I can't do cross matching properly. We said, okay, thank you very much, we made the diagnosis. Because if this happens, you are very sure you are dealing with mycoplasma. What is the treatment? Dr. Popat, 2 words about it, fast.
Azithromycin 10 milligram per kg per day. Azithromycin 10 milligram.
Okay, azithromycin?
Or
some people give doxycycline. What's the reason for that?
Also, doxy is also okay.
Yes, your take is?
Sir, head-to-head study done in our AIIMS Bhubaneswar, doxycycline is proven to be more beneficial in favor of azithromycin.
Dr. Chitkara, final word.
I'll start with the macrolide. If no response with the diagnosed mycoplasma not responding to macrolides in 3 to 4 days, it is time to put an alternative drug. We can use doxycycline and levofloxacin, either of them.
So, I'll tell you, in my practice, in my OPD patients, walking pneumonias, I always give azithromycin, and if patient doesn't respond, but most of the patient responded. But in an admitted patient who is very sick and with the respiratory distress, we prefer to use doxycycline in such cases. And there have been occasional patients, I'll say one patient maybe in every 3 months, where you may have to give steroids because this is a lot of autoimmunity which comes into play in a very serious patient. Do ferritin and LDH in such cases, and you may find that they are very high, indicating that you need to give steroids to suppress this. Okay, we go on to the next case. This is case 4. Dr. Subhashish, again I come to you. 5-year-old, high fever, 39-40 for 2 days, mild cough, less active, respiratory rate is 40 per minute, focal crackers only on the right lower zone, SpO2 is 96. Your diagnosis and how will you manage?
This case is more or less the findings, that is that there is fever, there is respiratory rate is higher, that is tachypnea is there is a crackle in the right lower zone which can happen in the later part of the pneumonia also, consolidation also. But this is the overall this picture tells about a pneumonia and a lobar consolidation most likely in the right lower lobe. So far as the management is concerned, if I am sitting in Calcutta in my OPD, I will definitely advise for a chest X-ray and as well as for a blood count also. And if the child is not too toxic, can accept oral feed and fluid, then I will start with amoxicillin or coamoxiclav.
Coamoxiclav or amoxicillin?
Yes.
Both?
No. I may start with the amoxicillin because
you will start with one thing. You don't start with
amoxicillin.
Amoxicillin. Okay. What about Dr. Popat X-ray? Sick nahi hai bacha, might want to do radiation, it's a community acquired pneumonia.
Child is having high grade fever, child is less active with tachypnea. So definitely investigation has to be done, including CBC and X-ray, and depending upon the results of both this, we decide whether to admit the child or whether to not to admit the child. If it's a strong
will X-ray decide admission?
If there is a high count, strong evidence of an lobar pneumonia with a less active child with tachypnea, I would like to admit the child and treat the child. If both the investigations are reasonably okay, no major signs in the positive in the X-ray or count is not that high, we can definitely treat with the oral
Suppose
antibiotics.
the patient has come in the community to a peripheral worker. So this is definitely a classical case for antibiotics to be given in this child.
Yeah.
That's right?
Yeah, definitely.
Okay. And X-rays we should not be doing, and I think in practice a lot of people get it done to be, I think, more sure to sort of convince the parents rather than convince themselves, because they know that this is going to be pneumonia only.
So there is a medical legal aspect. If I am practicing in the city, if I do not do an X-ray and if there is a complication, then there can be a medical legal aspect also. You are absolutely right. If I am sitting in a resource poor setting in a rural part, then I may not do the X-ray and start amoxicillin. But if I am doing my practice in the metro cities, then I will definitely, and 99% of the pediatrician will do an X-ray and CBC to start with the treatment.
अच्छा डॉक्टर पोपट एक क्वेश्चन रेज करा था, amoxicillin or amoxiclav?
Amoxicillin is sufficient enough if the child is not that sick.
अगर
The
ज़्यादा
child is
sick है,
not as
if more sick,
if the child is do not
more
be-
sick, is very sick, then amoxiclav?
very sick child, then we need to hospitalize the child and go on injectable
And
antibiotic.
what antibiotic?
Either ceftriaxone or coamoxiclav.
Okay. Your take is same, amoxicillin?
Same, sir. If very sick,
Why
then
amoxicillin? Why not amoxiclav?
Because sir, there's
ज़्यादा कवरेज है, बड़ा है, ज़्यादा ग्रुप कवर हो जाएगा, ESBL भी कवर हो जाएंगे थोड़े बहुत.
Sir, why to use CLAV? Because the child is very naive to us, not taken any antibiotics. Why to? Because amoxicillin have a good response over the.
बालाजी की स्टडी है, उसमें बड़ा रेजिस्टेंस आ रहा है in meningeal isolates in 2017 study.
But sir, in the community acquired state, it is amoxicillin is the drug of choice.
डॉक्टर चिटकारा कर दे अमोक्सिक्लेव.
तुम मारोगे अगर मैं अमॉक्सिक्लेव करूँगा तो. But ideally I would start amoxiclav. I tell you the reasons for that. Number one, 5 year. It is not that 5 year one day you will don't have H influenza B. Or 1 year, 1 day less than 5 year you will have H influenza B. So these are arbitrary.
So this child is in my practice.
Let me
This child is in my practice.
So
received vaccines, including hip.
No, you are assuming things. So one, I would cover H influenza B. Because you have not given us the long clinical details, except that this is definite pneumonia which is evolving on just 2 days history and kind of a focal signs being there. Number two, why couldn't it be staph? So my amoxi alone will not cover staph. So sitting in an OPD, while the time I am getting an X-ray chest, I would use amoxiclav. In next 48 to 72 hours, if I am reasonably certain it is not staph, it is not H influenza, it is strep pneumonia, I would put him on amoxicillin. So de-escalation is not only in ICUs, de-escalation can be in the OPDs also.
Okay,
Sir,
I beg just. I wanted difference of opinion, but not so much. Anyway.
No. I beg to differ in one so point that it is unlikely to be staph.
Just a minute, let me summarize. We have very little time left. Let me summarize. This strep pneumonia does not get resistance by having beta-lactamase. So there is no role of adding beta-lactamase, number one. At 5 years, I am not thinking of H influenza. So amoxicillin alone is definitely enough. And with this, I close this chapter. I don't want to discuss further. So if I summarize the whole thing, I'll summarize like this, whatever we have discussed so far. In bacterial infection, the fever is there, high fever is there, and the cough is minimal at the onset. And there can be blood-tinged sputums in some cases, it's very classical, and chest pain and lethargy, bronchial breathing and crackles unilateral. Viral, gradual onset, 3 to 5 days, mild cough, runny nose, sore throat, wheezing is there, fine crackles and rals are there. Mycoplasma, more gradual onset, 5 to 14 days, mild cough, cough present, hacking, dry hacking cough, child may have fatigue, myalgia, headache, rash, arthritis, all those things. Symptoms are more than the signs and you may have these features. I am going to take this, although there are 2-3 cases, I will take this as a last case. This is because these 2 cases are MRSA, one is with MRSA bacteremia and one is just MRSA and lung infection. So I will take only this case because rest will be discussed by Dr. Bala in his presentation. High fever, 4-5 days, cough, sick looking, admitted with respiratory distress, X-ray chest and ultrasound done, blood culture sterile and the pleural tap shows MRSA and discussion on the management will do. And if you see this, I think it's visible here. So you can see this is a classically MRSA, you have cefoxitin screen is positive and we'll do a prompt source control. The child needs appropriate antibiotics and supportive care. I am going to the panelist. Sir, everything MRSA drug sensitive. There is no inducible resistance of clindamycin also. So with this, what is your choice of antibiotics? Anyone?
The child is sick, but hemodynamically the condition is not mentioned. If the child is sick but hemodynamically stable, I can go for Clinda as the first line because it is a community acquired.
For Clinda?
Community acquired, not hospital acquired MRSA. And if the child would have been very sick, hemodynamically unstable, low BP, shock, then definitely I could have gone for a vancomycin as a drug of choice. But daptomycin for lung infection is not a good drug.
Absolutely. Daptomycin is out. Okay.
Linezolid.
I'll use linezolid.
Linezolid first.
Yes, Dr. Popat.
Linezolid first. And
Yes.
if there is a septicemia along with, then vancomycin.
Yes, sir.
Ceftriaxone, clindamycin.
Okay. So, this is a Delphi analysis done by Dr. Tannu, Kamila, Rajiv Soman and Chand Vathal. And in this, they have given this argument that teicoplanin should be preferred over vancomycin in MRSA pneumonia in view of it gives higher levels in alveolar epithelial lining fluid. And what is this epithelial lining fluid? This is a thin layer that lines inside the alveoli and small airway. In vancomycin, ALF is 15 to 20% of serum. In teicoplanin is 30 to 40%. I felt quite impressed with this study which they have quoted. Then I went to the literature and found it depends on a lot of things, MIC, time about the MIC is AUC, bactericidal activity, host factors, ELF, and then secondly the Americans have a bias against teicoplanin. So we found they have almost equal results. Teico is nothing superior. But as Dr. Chitkara and my panelists are saying, many people use linezolid. Actually, it has the best lung penetration. You can't use this drug particularly if there is a associated bacteremia, because it's a bacteriostatic drug. Now, ELF levels often are more than plasma in this case, means it diffuses inside this ELF. It's preferred in severe lung disease, particularly if you have necrotizing pneumonia, abscess and empyema, low protein binding, excellent tissue penetration, and it is recommended in all this, particularly if this. But there are 2-3 concerns. I want to discuss this and end with this. What are the concerns we have regarding linezolid?
Number one, it is a bacteriostatic drug. Number two, it has got a anti-tubercular effect. So, though its case not seems to give very tuberculosis-like picture, very short duration. There is
but there is an elephant in the room. What is that?
Sir?
There is one elephant in the room. What is that? The elephant in the room is basically this is a drug we want to use for tuberculosis, and we are having a lot of resistance in tuberculosis, and this is a very good drug for resistant tuberculosis. If you use it left and right, then in that situations your concerns are there. And then secondly, the side effects, and the side effects are bone marrow suppression, thrombocytopenia, neuropathy, optic neuritis, and because of and lactic acidosis. So these are the concerns I have. With this, I end my topic, and with one very interesting thing, and that is 2 slides. We had a case of severe complicated pneumonia. In this case, the counts were 1300, and this is the look of the X-ray. The child was very sick, hemodynamically unstable, straw colored, this thing was, fluid was there, exudate, polymorphonuclear response, and we were giving antibiotics, meropenem, vancomycin and clindamycin. We make the child survive after 6-7 days, and to de-escalate we did pleural tap, and it was we subjected this to out of this one panel, that is joint panel, and it turned out to be staph pneumoniae, and this is how we can de-escalate and use antimicrobial stewardship in our practice. Thank you very much.
Thank you, Dr. Sham. May I request the moderator and the panelists to come to the
Ajoji group photo
for the distribution of mementos. Next, I'd like to next session is masterly opinion. Masterly opinion. I'd like to call our chairperson, Dr. Kalpana Datta and Anup Kumar Mangal. Kalpana Datta and Anup Kumar Mangal. Anup, are you there? Oh, yes, he's there. Please come. অ্যানাউন্স করে দিচ্ছি না। बोल रहे हैं Good morning, everybody. The topic is today acute otitis media management. This is always a controversial issue. The speaker is no other than Dr. Chetan Trivedi. Please come to the dais and start your speech.
Hello. Good morning, friends. At the outset, I will fail in my duty if I don't show my gratitude and thanks to team Summer CME Kolkata for the fantastic show as well as giving a brilliant opportunity to me to be here. Now, as this topic which I am going to talk is acute otitis media in children, and it is not something very fancy which I am going to do, because when we have an infectious disease conference, we have two types of sessions. One is excellent super specialist session, maybe Dr. Kukreja and Dr. Bala sir all are discussing, and there is one which is for general pediatrician, and I am representing general pediatrician, all of you. So when it comes to acute otitis media, we know that it is a very common thing which is occurring in our day-to-day OPD. When I am presenting a presentation, like, it cannot be without your participation. That's why I'll be doing a mentee also with you. So I'll be taking your opinion when I'm doing my journey towards this case presentation. So first, before I do anything, just scan this mentee, keep it with you. It will come to you, the question will come to you, and you have to give your choices, and that will guide me further how should I go ahead. Prizes है, फिक्र मत करो, कल आपने जो कलेक्ट किया वो दे देंगे. Okay, fine. So now, case number 1, I will directly go to that. Just look at this mentee thing. The case will be there in front of you. So, 18 months old male child brought with a fever which is high grade, running nose, cough, excessive crying, irritability since 2 days. Previously healthy, no antibiotic received. Now, I will ask you a question. What next will you do? Either you will go and send a urine routine micro, you will send for the ultrasound abdomen, you do otoscopy, or you send for the CBC CRP. Your opinion. 18 months old boy with excessive crying, irritability, fever, no history of antibiotics, previously healthy child, what will you do? You have 4 options. Hope you all have given the answers. 30, 40 people. Almost 62 people are participating out of that. Okay, so I am just closing the poll. Okay, so 70% of us are thinking that yes, we should be going for otoscopy, and that's a correct answer, I see. So, of course, in our practice, we should not be indulging into the right away going for investigation or something like that, but you think what we are dealing with, and if we are dealing with something which requires something which is very much there in your OPD, we should do it, and that's what important is otoscopy. So always suspect otitis media, that is the first message. How common it is, why we are discussing this? Because if you see, by age of 3 years, almost 70 to 90% of children will have at least one episode of acute otitis media, and 40 to 50% will have recurrent episodes. And if it is the acute otitis media, we know that it is a reason for prescribing antibiotics, and it is a leading cause of antibiotic prescription in young children. Now, age distribution, if you say it peaks between 6 months to 2 years, that's the one thing. Less than 6 months, because of maternal antibody, we don't get much of the cases, but still they are there. Lastly, it declines after age of 5 because there is a eustachian tube function that improves. So that is one thing. Now, let us try to understand why acute otitis media occurs. We know that is a tympanic membrane. Within that, that is a medullary cavity, and that is air-filled cavity. Now, when you have upper respiratory infection, you get eustachian tube gets inflamed and it gets blocks. And you know that what is the reason for eustachian tube? It keeps the difference of pressure out of the tympanic membrane inside the tympanic equal. So if there is a blockage, there will be negative pressure, and because of negative pressure, the mucosal surface will start oozing, and there will be fluid collection, and this fluid collection will get infected, maybe by bacterial or viral infection, and that will cause a fluid which is collected behind the tympanic membrane. So what will happen? It will press the tympanic membrane, and once it presses the tympanic membrane, there will be bulging, and once there is a bulging, definitely there is signs and symptoms of acute otitis media. That is the main reason why we are dealing with this acute otitis media, why it is happening. So this is very important, basic thing. Now why it is so common in children? That's only another question. We know the eustachian tube, if you can see here, it is horizontal more a bit, if you see here. So as compared to adult, it is a horizontal, it is smaller, it is, shorter, and it's a long round opening. And because of that, it is more chances that eustachian tube gets damage, particularly frequent upper respiratory infection. Daycare exposure, and most importantly, bottle fed children, they have been given bottle feeding in the sleeping position, that's the reason. Indian context, if you say high burden because of crowding, recurrent infections, and limited follow-up, hardly people will come to you for these kind of things. So they may take analgesic or something, eardrops, and they'll stay home. So now, in my case, I revealed this. So when I did the otoscopy, I found this. Now my question is, which of the following criteria must for the diagnosis of acute otitis media? I'll give you the option first, then you go to the role. Erythema of tympanic membrane, high grade fever more than 101, acute onset of symptoms, or bulging of tympanic membrane. Just give your poll. What do you feel that is very important criteria for diagnosis of acute otitis media? Okay, let me see. Okay, so there are 38% they believe erythema of tympanic membrane is must for diagnosis, and 31% it is changing. So majority of people are going with the majority. So let us see. So how do you diagnose acute otitis media? First, what we did, right thing, suspect acute otitis media with proper symptoms and signs and age group. Okay, fine. At the same time, you go for otoscopy. Otoscopy is must. Or if you have a new onset ear discharge, which is not because of acute otitis externa, then it is otitis media. Now when you talk about otoscopy, what will you see into it? Yes, middle ear effusion has to be confirmed. How do you confirm? As I said, pathophysiology, middle ear fluid, it bulges, makes the tympanic membrane bulge. So if there is a bulging of tympanic membrane, or if you have a pneumatic otoscope and if you see there is a mobility is less or it is absent, then it is your fluid is there. So you have to prove that middle ear fluid is there in presence of signs of inflammation, that is erythema of tympanic membrane. So what is more important is bulging of tympanic membrane, of course in presence of the erythema of membrane. So that is second thing. Any blood test required? No blood test. It is a diagnosis by otoscopy and clinical findings. Okay. Now when we talk about otoscopy, how many of you are doing otoscopy in your practice? I think 30-40% hands are raised. Fine. Those who are doing it, are you doing with routine otoscope or something else? Routine otoscope, how many? They are really very knowledgeable people, very good at the technique. But what I do, I just share. I use digital otoscopy. And this is something, pen-like thing. This is pen, see. This is introduced, lift the pinna, and then you connect it with the Bluetooth to your phone. And can you see this? Very beautifully. This is a tympanic membrane which is pale, transparent. This is normal tympanic membrane. Isn't it good? Because many times it will become, because with a person like me having a progressive, it is difficult to adjust the otoscope. That's the problem. So this digital is very convenient. Okay, fine. So now let us come to the organism. Acute otitis media, we have diagnosed by otoscopy. What are the common organisms? And my question is, choose the right one. The following are the commonest organisms found in a acute otitis media. NTHI, Moraxella culturalis, Streptococcus pneumoniae or Streptococcus pyogenes. Which are the commonest organism? Commonest I am asking. Maybe all of them can cause that, but commonest is, because that is very important for us to understand how will you choose your antibiotics. Yes, but I am just talking about bacteria in that. You are right, absolutely right. I will come to that. Yes, everybody, almost majority of us, we believe that it is a Streptococcus pneumoniae, which is the commonest cause of bacterial infection. As sir said, right, yeah, viral also common. So what are the other organisms? Yes, bacteria, Streptococcus pneumoniae, H. influenza, Moraxella culturalis. Viral infection, we have seen many patients of otitis media in influenza. There was a peak of influenza season, and you know where we have standard treatment guidelines that if when is acute otitis media, start with antibiotics. That is one of the indication of starting antibiotics. But we have seen that many times we fail with antibiotics and we have to start with oseltamivir. That has also happened. But no, commonly if you find, this is the main reason to start with antibiotics. Okay, fine. So let us go back to a case, 18 months old, or same, you have seen otoscopy. Now, what about the treatment? Do all the cases of otitis media need treatment, or can we have a wait and watch approach? How do you decide? Decides on three things: age, laterality and severity. If it is severe, what is severe? It is a fever which is 102, 103, high grade fever with there is a severe otalgia. That is severe. Laterality, unilateral, bilateral. Age, less than 2 years, more than 2 years. So, depending upon that you decide. When you do the wait and watch approach, watchful waiting only if it is unilateral, non-severe and a child above 2 years. Then you can. Because why? Because this kind of otitis media can resolve by its own. And that's why we want to have an option of watchful waiting. We don't want to use antibiotic unnecessarily. So now you can have this chart. Acute otitis media you are diagnosed. If it is less than 2 years, if it is severe, otorrhea is there, treat it. If it is non-severe, 6 months to 2 years, unilateral, you can have wait and watch approach. If it is non-severe but bilateral, start away treatment. Now here, if it is less than 6 months, you are suspecting, may not be able to diagnose by otoscopy. If you are having a strong suspicion, you may start with antibiotics. So that is one more caveat, it's less than 6 months. If it is more than 2 years, non-severe, watchful waiting, more than 2 years, severe otorrhea, treat it. So you look at it, whenever there is otorrhea, you have to treat it. So there is no option. So whenever there is a past discharge coming in, you have to treat. Okay, fine. In our case, it was less than 2 years, severe, we decided to treat. Now we decided to treat. What next? Choice of antibiotics. Let us have your opinion. Choice of antibiotics, in our case, where is the first episode of acute otitis media, no history of amoxicillin, child was healthy previously. So there are options: amoxicillin 40 to 50 milligram, normal dose, high dose amoxicillin, amoxiclav or azithromycin. Okay. Okay, so there is a tie between more or less amoxicillin and amoxicillin high dose and low dose. So those who are even using Nelson or international guidelines, they are more in favor of high dose amoxicillin. But in India, still we have enough evidences that amoxicillin routine dose, Streptococcus pneumoniae responds to that. So that was discussed in previous session also. Amoxicillin is the first line. Now, if there is a penicillin allergy, definitely if it is non-IgE mediated, you go for cephalosporin. If it is IgE mediated, you go for azithromycin or clarithromycin. Now, any other treatment, analgesia is very important. Never ever forget to give painkillers. Maybe a paracetamol is fair enough, or ibuprofen. Now, what about role of decongestant? Limited or no role? Now, most important question, installation of ear drops. What about topical ear drops? Any role? No or some role? Okay, topical antibiotics role, topical analgesic no role. There are some data, few studies which show some role or non-inferiority but not specific role. Now topical antibiotics, there are specific role if there is a perforation, if you have put a eustachian tube, if it is chronic superiority otitis media, you may go for topical antibiotic but not in routine case of acute otitis media. Particularly when pus is coming out, the antibiotic is not going to go inside. So when you are sure that antibiotic, your drops may go inside, you can use it. That's the only carry-on message. So analgesia and your antibiotics. This is the basic treatment. Now I have started antibiotic. How to ascertain the response? We have to see the response 48 to 72 hours. If there is improvement in pain, fever, ear symptoms, yes, fine, you continue the antibiotic. Less than 2 years, we'll continue for 10 days amoxicillin. If there is no response, then in that case, after 72 hours, you may shift to either amoxiclav, you go for maybe a middle segment, amoxicillin high dose, amoxiclav, or if it is already an amoxiclav, you go for the parenteral ceftriaxone, or if it is resistant and rather allergic and you are on macrolide, you go for levoflox. That's the way we go ahead. Now, which are the situations where we prefer amoxiclav upfront? When we not want a BL-BLI combination. So beta-lactamase producers are seen. What are the conditions? That will give you clue. One, there is no response to amoxicillin. Second thing, if you have conjunctivitis, there are chances of H influenza. Then third one, if child has already received amoxicillin in last 30 days, these are the situation, upfront you go for amoxicillin. There, normal dose amoxicillin. So, how long will you give? If it is less than 2 years, 10 days, 2 to 5 years, 7 days, more than 5 days, 5 years, 5 days. That's how long. Now, child has responded apparently, clinically fine. After 15 days comes back to me with a fever, cough, cold. And I again checked for the otoscopy. What I found, can you make it out? This looks more dark over here, but here it is pale. I am telling you, there are air pockets if you can see, and there is fluid behind it. So now what is this? I'll ask you. What will you do? You start with amoxicillin, you start with azithromycin, you start with oral steroids, or you will just be watchful waiting. Now, this is very important question. I would like to have your opinion. Quickly. I have only 5 minutes. 2 minutes I have to spare for Khea. Okay, so there is a tie again between starting amoxicillin. People are thinking 15 days have passed and amoxicillin already given. So amoxicillin, okay, fine. Watchful waiting. Those who are going for watchful waiting, I will be with them. Why? Because this is a condition called otitis media with effusion. It is not acute otitis media. It is a pale, there is air pockets, there is improvement has started. And you know that the fluid might persist for almost as long as 12 weeks, so 3 months. So if you don't have acute otitis, the finding of acute otitis media, acute signs of infection, then it is otitis media with effusion. So it usually resolves completely by 3 months. So just wait, don't overtreat. No antibiotics, antihistaminic, decongestant or steroid. These do not improve the long-term outcome. So in this condition, just wait and watch. So now suspected OME, confirm the diagnosis. We did the otoscopy. Then you keep on looking at it. If there is any complaint, like, if straight away if you have a speech delay, Down syndrome, cleft palate or developmental disorder, you directly go to early hearing screening, evaluation, go for ENT referral. But if you wait and watch, meanwhile you check for the symptoms. If there are any symptoms of hearing difficulty, you go for early hearing evaluation, ENT referral. But nothing is there, you can be watchful waiting and till 3 months you wait. Now, after 3 months, suppose if you have response, don't do anything. If you don't have, you have the persistence of that, then go for hearing assessment, send for ENT referral. If it is hearing deficit, then ENT person will do tympanostomy tube. Now what is tympanostomy tube? Fluid is behind the ear. You want to drain it. So how you can do it? You can do a myringotomy. You just put an incision, put a grommet, a tube, which will keep the things, both the part open. So the fluid will be drained. So pressure will go down. So this is something, many a times we may not have seen it. So if you see this kind of tube, which have been put in after doing myringotomy. And then what happens, that this tube, it comes out by its own. You don't have to remove it just like a implant you have done somewhere in the bones. It comes out. There may be 6 months to 12 months. So that will drain it. So that will make the inner ear dry, middle ear dry. So this is what is happening. This is a grommet insertion. Now this is a condition, when we were talking about antibiotics, topical antibiotics, if there is a perforation, if they have put a eustachian tube, grommet, or you have chronic superiority otitis media, these are the conditions there is some role of topical antibiotic drops. Otherwise, in acute otitis media with intact tympanic membrane, no role. So finally, what are the complications? Yes, it may be a ear, bone and brain. So what is that? Ear, you may have perforation or chronic superiority otitis media. Bone, maybe a mastoiditis or petrorhitis. Brain, it may go to meningitis, abscess, sinus thrombosis. And hearing loss and speech delay is very, very important. So that's why early referral, you have to keep eyes and ears open, look at that. Now, there is something like recurrent otitis media. Because once you start doing the otoscopy, you get the patient, you diagnose it, you treat it, they come back again, you may have otitis media with effusion, then it comes again after 2 months, you get again, so recurrent otitis media. And you get frustrated many a times, because many a times, you get tired, these patients are coming again and again. You find that what is the reason? Maybe eustachian tube is at fault, as we know. Adenoids are the place, if it is enlarged, it will press on the opening of the eustachian tube. So that will cause again the blockage of eustachian tube. Infection, recurrent respiratory infection, that will provide. Environmental factor, if you have recurrent otitis media, ask anybody in the family smoking. Passive smoking is one of the reasons. Breastfeeding is not given and bottle fed with a supine position. So these are the common things which you find. And lastly, host factor can be the threat. So if you have immunity which is hampered, maybe less than 2 years, that's why it is again coming more common. Syndromes, maybe a Down syndrome or cleft palate. These are the situations where you get recurrent otitis media. So that is beyond the purview of this particular discussion. So now take your message, diagnose correctly acute otitis media, treat selectively, focus on your pain relief and watch for the complication. That's all I have to offer from my side. Thank you so much for being there in my journey of this case presentation. Thank you so much.
Thank you, Dr. Chetan Trivedi, for a nice interactive session. Though acute otitis media is quite common, but there's a clear conception was there. I will nicely explain and made the audience interact. Thank you.
Yeah, just an announcement on behalf of Dr. Chetan Trivedi, because he's a Mentimeter person. So always Mentimeter, you do get prizes. So what I am declaring on my behalf, the winner will get prizes once they travel to Ahmedabad for the Respi IDCon. Then Chetan will give prizes only to the winners who travel to Ahmedabad for Respi IDCon.
This is a true organizer.
Okay, I think is questions allowed? Can we take the case question? Can we take the question as the one of the audience asking? Okay, sorry, we will talk. We will ask the question later on or in the off the desk. You can ask the expert of the desk. Okay. After the 2 lectures, we will take the session. So for the next session, I would like to call upon Dr. Khaya Ghosh is Uttam. She will be talking on sparing strategies in multi-drug resistant infection. Let's reserve and let us be aware of that. So stage is yours, Dr. Khaya.
Thank you, Madam and Sir. So the topic, as you can see, is reserve sparing strategies in MDR infection, and let us be aware. So basically the topic itself has 3 components. We will talk a little bit about the aware classification of drugs. We will have a component of MDROs, what are these bugs, and then we will have some interesting cases and how we have used the sparing methods to reserve the reserve drugs. So first the aware classification, is it coming? So what is an aware classification? I think many of you already know. So it is a WHO expert, it's not coming, expert committee on selection. They reviewed every 2 years. And oh, that's why it's so antibiotics are classified into 3 groups, okay? The access, the watch, and the reserve, to emphasize the importance of their appropriate use, and it is updated every 2 years. So the latest classification that has come in September 2025, which has again 3 groups as mentioned, and you can actually download it, and if you download it, you will get an Excel sheet, and if you click on this like this, the pointer is here, okay, yeah. So if you click, so I will do like this. So if we click here, like if you click on the access, you will get, yes, you will get this access drugs, and I have clicked on the reserve, so you are getting this reserve drugs. So we will restrict our use for today only on the reserve drugs and what are the sparing strategies are you. As you can see, many of the drugs which we often use in ICU, but many drugs like linezolid, we have a discussion on that, are in the reserve group. So we have to have very meticulously use these drugs, otherwise we will end up in a trouble within a few years. So first question, when to use the reserve drugs? So when you have, of course, proven MDR, XDR infection. Proven matlab you have got an antibiogram, you are seeing an MDRO, so you can use that. Severe life-threatening infections, where pending your culture report you can start. infections in immunocompromised children, so patients with bone marrow transplantations, on steroids, MMF, so these are the areas. And of course, you can use in non-response. So we have a lovely workshop on NRI, the non-response infection, which is the brainchild of Dr. Bala sir. So in that cases, sometimes you can use when your appropriate access watch antibiotic failed, and while you are investigating for the cause, under the guidance, preferably under the guidance of an ID specialist. So other than this, just don't touch these reserve drugs. So this is about the drug. Now what are these MDROs? I'm talking of MDROs. So WHO has again classified the bacteria into priority pathogen list, and we have these critical priority pathogens, of which the important is those who are doing ICU, mainly CRAB, that is carbapenem resistant Acinetobacter baumannii. Also we have enterobacterals, third generation cephalosporin resistance. Often we get in complicated UTI even in the wards. And we have this CRE, the carbapenem resistant enterobacterals, usually an ICU bug. And of course you have this rifampicin resistant Mycobacterium tuberculosis, which I will not touch because it's not possible to cover in 20 minutes. But of course we have the high priority pathogens also. Out of this, the most important is the Staphylococcus aureus methicillin resistant, or MRSA. So now coming to my third part. So how to keep this reserve drugs, and what are the sparing strategies we have in MDR infections. I will take the help of 4 cases to describe this, but just before that I would like to mention a mnemonics. This is an important stewardship concept of save the reserve drug. You know, this is what we have. This is, ACE is source control. We have discussed in many of our cases, source control or drainage of the pus, drainage of the removal of the lines is the most important and most underutilized thing in controlling MDR infections. And antibiogram guided therapy, and we will go as we go on to the cases. Now coming to my first case, which is a 21-day-old baby who came with an abdominal distension, decreased urine output. The sepsis screen was positive with a high CRP of 205, 21,000 count. Ultrasound shows an enlarged liver with a hypoechoic SOL in the right lobe of liver. And another small size lesions, thinking it to be a liver abscess. The antibiotic was upgraded to IV meropenem and IV vancomycin. And the blood culture shows MRSA, which is, I have shown you, it is a high, not a critical pathogen, but it's a high priority pathogen, which is sensitive to vancomycin, linezolid, and many other MRSA drugs. So on day 5, the abdomen distension suddenly increased, and the baby developed respiratory distress and tachycardia, desaturation, required ventilatory support. Now, the dilemma is, so should we investigate, explore, or drain, or should we upgrade and start the reserve drugs like linezolid? As already Dr. Cham has mentioned in his previous year, linezolid is not a very good drug for bacteremia, and there are thousands reasons why we should not use linezolid here. And we will go to that. So we investigated, explore, and drain, and this was the X-rays you can see. And surgeons were consulted. There was a ruptured liver abscess with intraperitoneal pus. So even with a sensitive antibiotic, you might have these scenarios. So unless you drain the pus, so intraabdominal toileting was done and drainage of liver abscess was done and vancomycin continued, no upgradation was done, clinical improvement starts. So what reserve strategies, what sparing strategies we used here? We used optimized source control, the source control. So most important and often neglected. So drain abscess wherever is there, drain empyema, remove infected lines, debride necrotic tissues wherever, so that you have a better control of the bug. And of course you have to go for an antibiogram guided therapy and try to use effective watch or access drugs. So we use 3 sparing strategies to control this reserve drugs. Stop, I would like to highlight one thing, stop linezolid misuse. So linezolid is only indicated if there is MRSA and where you are not able to use vancomycin, because it is contraindicated or not tolerated, or if you are using a penicillin-resistant Streptococcus pneumoniae, or a VRE, vancomycin-resistant Enterococcus, or in a drug-resistant TB. Restrict in these 4 conditions. Dose is 10 mg per kg et al. Give oral, its oral viability is almost 100%, and it is a very good lung penetration, as we were discussing in the last session. So it is often used not only in the hospitals but in the OPD for soft tissue infections of Staphylococcus or pneumonia, mild pneumonia. So linezolid misuse can lead to various consequences. Think of its hematological toxicity if used for a prolonged time, mitochondrial toxicity which can lead to severe lactic acidosis. And the dreaded complication is, dreaded misuse can lead to masking or delaying tuberculosis diagnosis, which is a great concern in area where, in India, where TB is so endemic. So empirical use will partially suppress the TB symptoms, so there will be delayed or modified clinical symptoms, and the diagnosis will be delayed. Microbiological diagnosis also becomes difficult if you have used linezolid, because there will be reduced maxillary load and hence false negative results, and it will promote drug resistance. So I will not go into the detail of the other drugs for MRSA because we have a session on Staphylococcus. Just to mention, we have ceftaroline, which is a 5th generation cephalosporin, and we have tedizolid, which is an oxazolidine dione, like linezolid, which can be used only single dose. So these are added advantage, but remember, all these are reserve drugs. So we should not, even we have a knowledge how it's work and everything, we should not try, even think of this, using this. So indication of ceftaroline is again community-acquired pneumonia and acute bacterial skin and soft tissue infection. But if we have drugs like trimethoprim, sulfamethoxazole, clindamycin, doxycycline for soft tissue infections, we should not go into this. So coming to our second case, where we use some other sparing strategies, is a 2-year-old child who is a follow-up case of nephrotic syndrome, now on remission, but came with a high fever for 3 days with an abdominal distension for 1 day. There was tachypneic, tachycardic, thready pulse, low BP, saturation 80% in room air. Investigation revealed CRP 83 with a count of 23,000 with a polymorph counts of 75. Urine and blood CS sent. And this is the blood CS report. I need the pointer. Yes. I am sorry, it's maybe, what is the bug? Can you say? These are all resistant. These are all cephalosporin. So what is the bug? I didn't know the Mentimeter is allowed, so I could have done that. So definitely it's a gram-negative because it is Klebsiella pneumoniae and it is an MDRO. Why I'm saying it, is it a ESBL producing? This cephalosporin are resistant, all are R. Is it ESBL producing? Yes, yes, everyone is nodding. So this is an Enterobacterus, which is 3rd generation cephalosporin resistant. Let's see whether it's a carbapenem is resistant also. Meropenem, the MIC is 4, equals to 4. I'm not sure whether it is clearly visible. So it is also an Enterobacterus with carbapenem resistance. So this is a critical priority pathogen, not like the MRSA, okay? So we have to use, so this is the Enterobacterus, I'm not going, and they have their resistance by production of either ESBL, when they are resistant to 3rd generation cephalosporin, the treatment is carbapenem. They can produce also carbapenems, which have different classes, where these are the common CRD organism, Klebsiella, E. coli, Enterobacter, where what are the drugs which will come into. And you can also have a resistance via AMC, where these are usually the bugs, Enterobacter cloacae complex and Klebsiella aeruginosa. So this also can produce resistance to 3rd generation cephalosporin, and here the treatment of choice is cefepime or carbapenems. So what drugs to use in our case? Can we use meropenem? It is 4. The MIC is equals to or more 4. Prabhash is here. Oh no. It can be used, but it is showing resistance. Why? Then how can we use this? We can use prolonged infusion of meropenem. Now most of the centers now prefer to use prolonged infusion of meropenem. And what is the reason for it? Meropenem has time-dependent killing. So bolus will have a high peak, but concentration of the drug will drop down very soon. But prolonged infusion, if you give a prolonged infusion, you have a sustained level above MIC. So it is used in severe infections with borderline MIC and should never be used if the meropenem MIC, if you see it's more than 16, it is not going to use. So critically ill with altered PK, increased volume of distribution in SOC. So this is the most important, another strategy to spare the escalation to reserve drug. So here what strategy we used? We used antibiogram guided therapy, and also we use valid PKPD optimization, where you use prolonged continuous infusion because it has a time dependent killing and a higher doses. Sometimes we use higher doses with safety, within your safety limits. Like in CNS infection of meropenem, we just double the dose of the meropenem. So this can make the access of the watch group of drug. In fact, don't think meropenem is a reserve. Meropenem is a watch group of drug. So this can make the access and watch drugs work against the borderline resistant organisms. So in borderline resistant organism, you use your PKPD optimization and use the spare, and don't touch the reserve drug. Coming to another case, a 32-weeker, a preterm baby was born and maternal history of UTI, so risk factor for sepsis, received first-line antibiotic in the NICU, developed respiratory distress on day 6, chest x-ray shows left and right upper lobe consolidation, baby was put on CPAP and then ventilated and transferred to our hospital. And here we did the bronchoalveolar lavage culture, which shows all drug pan resistance except colistin and polymyxin B intermediate sensitivity. So colistin, polymyxin B, never you will get sensitive. It is always intermediate sensitivity. The reason I will not, because that's the CLSI guidelines. So what is the bug? Here it is clear, MDRO, it is an Acinetobacter baumannii, carbapenem resistant crab, so which is a critical priority pathogen. So what are the drugs that can be used for this crab? So before that, just have a look at the major mechanism of antibiotic resistance. It has lots of, but these are the 4 primary things. They can produce enzymes like beta-lactamases like OXA23, OXA51. So this is enzymatic degradation, which is the commonly used. They also use active efflux pumps to expel multiple antibiotic classes like aminoglycosides. They have reduced permeability, and so they downregulate the outer membrane protein such way that the antibiotics could not enter. And very, very important, Acinetobacter has this property of forming a biofilm, as you know, in the endotracheal tube and all. It protects the bacteria from antibiotic penetration and the host immune system. So the drugs, what are the drugs we have for crab? It is sulbactam, durolobactam is the first line. Durolobactam is not available, so we use sulbactam with another active agent, which is usually polymyxins, minocycline or tigecycline in the case. So sulbactam, which is the first line, first generation beta-lactamase inhibitors, it has a very good Acinetobacter works very good with Acinetobacter because not only it inhibits the beta-lactamase inhibitors like class A, but it has an intrinsic antibacterial activity against Acinetobacter. So it binds with the PBP and inhibits the peptide. So it is the drug of choice. And durolobactam is a newer generation which is not available. The advantage is it has a activity against class D carbapenemase, which is produced by the Acinetobacter baumannii. So here comes the importance of the polymyxin, which is again a reserve drug, which is a group of cationic polypeptides, and they bind, as they are cations, they binds with the anions of the bacterial cell membrane and prevents the bacterial cell membrane, makes the cell membrane leaky, and thus degradation of the bacteria occurs. But it should only be used in hospital-acquired infection, ventilator-associated pneumonias, and complicated UTI as the last resort, very, very important, as the last resort when the other drugs are not acting, or you can use them with combination in a multi-drug resistant gram-negative organism, never alone. Another use of polymyxin is inhalation form, which is used in cystic fibrosis patients with pneumonia and chronic pulmonary infections. So here, what we did, it's a rational combination therapy which helps to improve the efficiency and prevents resistant emergence. So we use this sparing method to reserve. Now coming to the last case, it is a 12-day-old girl baby, came with poor feeding and lethargy. There was a history of respiratory distress soon after birth, and the baby was in the NICU, which is a risk factor for having hospital-acquired infection and then discharge. And the baby now came on the 12 days with this count, CRP 51, total count 16,000, and the blood CS shows this. I'm sorry whether you can see or not. So this is meropenem resistance. So this is MDRO carbapenem producer. This is also ceftazidime avibactam resistance. So this is a CRE, but the drug for CRE, main drug for CRE is ceftazidime avibactam, but this is ceftazidime avibactam also resistant. So drugs for CRE are usually given according to the enzyme they produce. If it is KPC, it is ceftazidime avibactam, OXA48, ceftazidime avibactam or cefiderocol. If it is NDM producers, you can give this ceftazidime avibactam alone will not work. You have to give both ceftazidime avibactam plus aztreonam. And if there is unknown mechanism and if cefiderocol is available, it has been licensed for children by 2016. So you can use that, though not easily available, so you can use that. So what is the sparing method we have to use here? It is the rapid diagnostic to know the gene. So you can use blood sepsis panel biofire, where you can get, or you can get like this. We have got the bug and you can use expert carba to find the resistant genes, and you can thus go for early identification of the resistant gene and faster de-escalation. But here what drug to use? I have shown it is ceftazidime avibactam which was resistant. So if you look at the report again, look at this. Here it is written the synergy test, that is ceftazidime avibactam plus aztreonam, synergy test was positive. So why routinely this is not given? You have to ask the microbiologist to give it, because CLSI does not give a specific rule for this. So we in our hospital do it by a yeast card, and so role of synergy test though is there, but it is doubtful in some of, because as there is no clear-cut guidelines. So if you have it, so if you have the synergy test positive, what you can think, it is an NDM producing, so it's better to go for a combination of drugs of ceftazidime and avibactam. So if NDM or VIM is detected, ceftazidime alone does not work. We have to go for ceftazidime avibactam plus aztreonam combination. And how does the combination work? Because ceftazidime doesn't have much role, it is a third generation cephalosporin. The avibactam is the main antibiotic. It is a non-beta-lactam. Beta-lactam is inhibitors, used mainly for CRE and multidrug resistant pseudomonas. It is active against all MC, ESBL, KPC, OXA48, but it does not work against MBL. So metallo-beta-lactam is. So aztreonam is the drug when it is combined with ceftazidime avibactam, because aztreonam is not hydrolyzed by the MBL. So MBLs cannot act on the aztreonam. So however, aztreonam gets often destroyed by the other enzymes. So if we combine, avibactam will protect the aztreonam and aztreonam will escape the MBL hydrolysis. So that is the rationale of combining the two drugs. And for that, it's better always to test for the synergy before administration, and it is given both drugs simultaneously over 2 hours simultaneously in two channels. So other drugs is a cefiderocol, which is not available, so I'm just skipping this. So you have other safe reserve drugs, because due to lack of time I cannot keep more cases. There were other cases of MRSA pneumonias. So start early de-escalation is very, very important. You start empiric, but narrow down once culture is available. Antibiotic guided therapy. So empirical use, restrain the other points in the safe reserve. So avoid unnecessarily empiric coverage, because so if you are in an ICU, a very sick baby, collapsing baby, you can start, but don't otherwise narrower therapy is preferred. Enforce stewardship programs in every hospitals, audit and feedback. So you should have an antimicrobial audit and restrict reserve drugs and require justification and approval. So even in our NICU, we have a file. If any consultant change the antibiotic, you have to give the reason why you are changing this. So this is very, very important. And of course, the most important thing is vigilant infection control. And what we follow is an A, B, C, D, E. Antibiotic use judiciously, blood and body fluid culture, should have the habit of sending culture, so blood and body fluid culture, clean hand, clean surface, clean procedure. It's not necessary to wear a gown, but your hands should be clean. Proper use of the devices and the design of the NICU and PICU is very important to improve infection control. And of course, start early enteral feeding. Try to avoid IV lines as far as you can. With this, I thank you for your time and patient attention.
Thank you, Dr. Kher. This is nicely explained, because nowadays we are very much in the news that the antibiotic stewardship. And as you said, the watch, reserve and the access drugs. But it will be surprising to know all the reserve drugs are resistant. We had a meeting with the government of West Bengal and we saw the watch drug and access drugs are resistant and all the reserve drugs are resistant. Rather, the watch drugs are coming to be sensitive. So recycling is started already. So we have to be very cautious about the antibiotic use. Thank you, and because of lack of time and from the organizers' suggestions, we are not going to take any questions. Any questions is there, it will be answered in the off the dais. Thank you for the session. Thank
you. I request the chairpersons and the speakers, Dr. Chetan Trivedi and Kya Ghosh. I request Dr. Apurva Ghosh kindly hand over the mementos to them. So now we have a very interesting panel discussion, that is Staphylococcus infection case-based. So I call upon Staphylococcus infection case-based discussion, moderator Dr. Bala Subramaniam, and the panelists are Dr. Abhay Shah, Dr. Jayan Joshi, Dr. A.J. Chitkara, and Madam Narmada. Please take your seats.
Good morning. We are going to have a discussion on staphylococcal infection, and this is going to be a case-based discussion. We have four distinguished panelists, starting with Dr. Chitkara, Dr. Abhay Shah, Dr. Joshi, and Dr. Narmada. The focus in this session would be a brief recap of antibiotics for staphylococcal infections, a few case scenarios of staphylococcal infections, mild as well as serious, and of course we have picked up cases where there are dilemmas in the choice of antibiotics. We will become wiser with our experts' inputs, and of course, in the end, we will always give a sermon with summary of and take-home messages. If I were to ask all of you, we are talking about aware classification and rare conditions like carbapenemase, resistant bugs and all. Some in the audience would not see cases. Is there anybody in the audience who has not seen a staphylococcal infection? Please raise your hand. Of course, all of us see, isn't it? All of us see. And as seen in the diagram, the infection can be most trivial with the nuisance pyoderma impetigo to the most serious meningitis or brain abscess caused by Staph aureus. And in between there will be some infections like gastroenteritis, food poisoning, which we rarely diagnose and treat, pneumonia, staphylococcal pneumonia, bacterial tracheitis, STI, okay, sinusitis, orbital cellulitis, endocarditis, renal abscess rarely, thrombophlebitis very frequently, nosocomial, wound infections. And of course, two conditions which are really not infections, which are toxin mediated, namely toxic shock syndrome and skin scalded syndrome. I am sure at least a few of these conditions all of us would have seen in practice and treated. Okay, let us have a recap of the antibiotics used for staphylococcal infections. Let me ask Dr. Chitkara. Dr. Chitkara, how do you classify staphylococci with regard to antibiotic before we move into the cases?
Okay, I think the first thing you must remember is whether it is a methicillin sensitive or a methicillin resistant. Now, having said that, if you have decided, because the drug spectrum antibiotic susceptibility is entirely different. Now, once you have decided MSSA, MRSA, now is the time to classify or kind of group your patient into a mild, localized, what is the site involved? Systemic or localized? Are there any comorbid factors? And severity, if you have to hospitalize or not. So start with a microbiological definition of an antibiogram, followed by these things, and these three things are important because your choice of drug, your choice of oral versus IV, your choice of hospitalization would depend.
For a practitioner, he has to decide whether it should be treated as OP or IP, oral drugs or IV drugs, MRSA coverage or not, and what drug. That's it. Okay. And of course, mild, moderate, severe, it can be very mild like impetigo, very serious to sepsis, etc. And basically, the microbiology will classify and use several, terms. MSSA, methicillin sensitive staph aureus, most common. MRSA, all of us know, methicillin resistant, that means it is not responsive to beta lactams. Community acquired MRSA, if it comes from the community, hospital acquired PICU bug. Visa is not a passport related affair, it is vancomycin intermediate sensitive staphylococcus. VRSA means vancomycin resistant based on the MIC, which we rarely see. Now let us walk through some case scenarios with regard to choice of antibiotics. Dr. Abaisha, this child, 2 years old, has skin lesions like this all over the legs like this, absolutely well child, no fever, no lesions elsewhere, and question that comes to us, should we treat this first of all, and if we treat this, we should treat with topical antibiotics or oral antibiotics or both, Dr. Abaisha?
Yeah, so it's a very well circumcised, very localized area, and as rightly mentioned, that child is well, it's not toxic, no fever. So I think there is no systemic manifestation. I will examine the child from hair to heel, and if there is no other disseminated areas infected, only local lesion, I think topical 2% mupirocin is fair enough. So this child does not require, because there a crust is there, so it seems to be a case of impetigo, only localized, no systemic manifestation. I feel topical antibiotic, that is 2% mupirocin fair enough. But if the same child has the induration of cellulitis is there, probably I go for the systemic antibiotic.
Okay, dermatologists use several terms, bullous impetigo, furuncle, cellulitis, erysipelas, abscess, etc. Now, for a pediatrician, he has to take a decision whether he is going to give topical or systemic antibiotic. Dr. Abhay, when will you use topical antibiotics alone?
So
when will you use systemic antibiotics for all these SSTI? Very common practical question in our practice.
So when the skin infection, there is the danger area of the brain, probably I would not like to take any chance and will take start with the systemic antibiotic. If there is multiple areas affected, I will start the systemic infection. If there is failure of the topical infection, I will go for the systemic infection. If the child is immunocompromised, very malnourished child, I will not take chance and probably I will go for the systemic infection. So, and the area which are not accessible, where the topical application is not possible, again I will go for the systemic.
Abhay, I have a doubt. You know this is staphylococcus, this can become dangerous. In spite of this, you treat only with topical. What is the philosophy behind it?
No, because see, this is that it is not the situation where you need to try hit very hard with the step, because
same staphylococcal pneumonia you hit hard, but why do you
because
not
the pyoderma is not going to kill the child. That is very important. So what is important is what the target alignment rate. So I need what I want to achieve with a particular antibiotic topically. That is very, very important.
Excellent. So when do you use systemic antibiotics?
So I already mentioned all these conditions that when multiple areas are affected, when you are involving the danger area of the brain, when there is bolus impetigo, when the child is toxic, some systemic manifestation is there, and when the high risk patient immunocompromised child on steroid, and when there is a failure of the topical therapy, these are 5 or 6 indications where the systemic antibiotic. And remember that the drug of choice is going to have first generation cephalosporin, that is cephalexin or the cefadroxil. There is no role of the azithromycin, there is amoxiclav is going to be overkill, quite a broad spectrum. So only cephalexin or at the most cefadroxil.
One peculiar indication is lesions around the mouth, because the baby will lick the mupirocin ointment and will not allow the baby, the mupirocin to act on the staphylococcus. Now what about the drugs, Dr. Abhay?
Yeah, so first generation cephalosporin, cephalexin and the cefadroxil, because we want to cover either Streptococcus pyogenes or the MSSA in general. Of course, in that case probably MSSA and this MSSA and Streptococcus pyogenes, cephalexin and cefadroxil is fair enough.
Why not use amoxiclav?
It's a overkill. I already told you. It's a broad spectrum. We do not, and the majority may not produce beta-lactam as enzyme as well.
Okay. One request to the audience here. Please adopt cefadroxil and cephalexin. The problem is if you continue to write cephalexin and cefadroxil, no medical representative will come to you. That's the only problem. Because it is so cheap. They are highly palatable, hardly used. Please adopt these two antibiotics for SSTI. Okay. Let us move to the next case.
Just one statement.
Chitkara.
Please never underestimate even a superficial staph infection. While we have suggested you to treat topically or maybe occasionally in extensive lesions, oral antibiotics, but when you see most of the cases which were presented by Shyam or will be presented, you always seek a history in staph suspected empyema, bacteremia. You seek a history of an impetigo in the past. So don't underestimate staph, but at the same time don't overtreat, but keep under a close observation or tell them the warning signs when to report back.
Okay, let us move to the second case directed at Dr. Jayant Joshi, the pulmonologist. Okay, Dr. Jayant Joshi, this is actually a 3-year-old child who had community-acquired pneumonia. Somebody rightly, based on the WHO recommendations, IAP recommendations, started on 50 milligram per kg of amoxicillin. Child worsened in 48 hours, became very sick, hypoxic, and an X-ray was taken. And this is the X-ray finding, Dr. Joshi. Now, if your comment on the X-ray and your diagnosis, Dr. Joshi, at this point.
Thank you, sir.
2 days of amoxicillin, not improved, worsening, hypoxic, X-ray taken.
So, as the clinical history suggests, there is a rapid worsening of the child over a period of time. Amoxicillin was started orally as a protocol drug. However, it has failed to give any good response. The X-ray shows definite consolidation in the right middle zone and the lower zone, and there is a possibility of a pneumatococcus there.
Okay. And here you will suspect staphylococcal pneumonia, yes or no?
Yes.
Okay.
Yes.
Once you suspect, based on your clinical judgment as well as on the X-ray finding of a fluid level and what looks like a pneumatococcus with fluid down, and you think this is a necrotizing pneumonia, this is staphylococcal pneumonia, what will be your antimicrobial choice as a pulmonologist? And if you say you choose something, I'll ask you why. Go ahead, Dr. Joshi.
Yeah, so I think this child has showed rapid worsening. Child is hypoxic, requiring oxygen support. So there is definitely a suspicion of a MRSA here. And because this child is critical, I would like to go for a anti-staphylococcal broad spectrum cover. Choice as either vancomycin or linezolid, being a pneumonia, would be logically looking like a better choice. But as you said, now linezolid is going to be preserved for the anti-TB therapy. So vancomycin seems to be the best choice here. And with that, probably we would start the treatment. But I would like to also add a beta-lactam here along with that to cover. So the best combination here would be a vancomycin and a ceftriaxone, or a vancomycin and a clindamycin, depending upon the severity. We would like to assess the child over a period of time If there is a good effervescence in 48 hours, we continue with the vancomycin alone, or otherwise we take a call.
Okay, now I am going to ask you, Dr. Jain Joshi, there are so many drugs in the list. In fact, we can put a voting also here and you will get multiple responses. Cloxacillin, cefazolin, vancomycin, linezolid, and somebody will say ticoplanin, somebody will say vancomycin plus clindamycin, somebody will say I will use even daptomycin. What are the pros and cons of each other?
See, basically, this
for
book,
this staphylococcal pneumonia, what looks like staphylococcal
so
pneumonia?
basically, when it is a staphylococcal pneumonia, it's a critical condition. There is a rapid worsening. So the choices like cloxacillin and cefazolin would not be relevant here because they would not be very effective for a MRSA.
So you will include cloxacillin in the regimen, is that right?
Not in this initial phase. I would be probably going for vancomycin
In this
straight
case,
away.
what will you use? This child has received amoxicillin, no other underlying conditions, no immunodeficiency.
No, but then the child has rapidly worsened. There is
Okay.
a nematocele already.
So what is your antibiotic of choice?
Vancomycin and ceftriaxone.
Okay, is there anybody who disagrees? Dr. Chitkara, I am trying to provoke you. No, he's keeping his hands like this.
Sir,
Right.
it depends where I am getting and what is the spectrum of staph I am getting. See, like in our OPDs, community acquired staph are invariably MSSA biograms. Anyone who has visited a health center before coming to us or has had some, disease treated thrombophlebitis and others, we think of MRSA. If the child is very sick and admitted with a moderate to severe pneumonia and it is a suspected staph, till the time we get a specific antimicrogram, we do cover for MSSA as well as an MRSA. However, if we are certain, then probably if I think MSSA, which is most likely the case in our centers, what we start with is either cloxacillin, which is available to us, or cefazolin is the second good choice. A slightest doubt of MRSA, or if I am given a diagnosis of MRSA, I would straight away start with linezolid in a pneumonia, staph pneumonia. I would not think of vanco, I would not think of dapto.
Okay, very well said. Now the choice starts with something like cloxacillin, traditional, MSSA, stable patient. You're not thinking of any risk factors, no toxemia, hemodynamically stable. Nobody is wrong if you use cloxacillin. In fact, even ceftriaxone will work against MSSA. Cefazolin is equally good. When you start thinking of MRSA, the gold standard is still vancomycin, vancomycin, vancomycin. Okay? And of course, linezolid is slowly becoming an equally important drug, and people are now slowly learning to accept linezolid also may be used. Definitely you should not use daptomycin because it is inactivated by your surfactant and the drug will not work at all in pneumonia and left-sided endocarditis. And severe MRSA, toxin-producing illness, in addition to vancomycin or linezolid or vancomycin plus linezolid, you can even consider adding the third drug, clindamycin. Some authorities in desperate situations, severely ill patients use all the three to suppress the toxin. Now, invasive staphylococcal infection, Dr. Narmada,
Sir,
go ahead.
you have already provoked me.
Yeah.
So, I would comment on the summaries you have made.
Yeah.
So, number one, if you have a definite, see, there is a medical hesitancy and a medical dogmatism when it comes to staph. If you see IDSA, which is our gospel truth for us, has not given any monograph after 2011.
Yeah.
Yet it has lent its name to many of the meta-analysis and systematic reviews. If I talk of now the current situation following a 2023 meta-analysis and a very recent review published in 2025 on the staph, we have to remove our preconceived concepts of bacteriostatic versus bactericidal. We have to remove our concept of a combination therapies not to be used. we have to remove our concept of what kind of drugs for toxin production, and at the same time, if you are MRSA, 95% go on a linezolid step down. Yet in the first 1 week, you are afraid of using linezolid for pneumonia. I am talking of only pneumonia.
Okay.
So there are some standard conventions and there are some evoluting concepts which are developing in the recent time. So
Agreed.
please take into context that.
Well said, well said. Now, Dr. Narmada, now we talk about invasive staphylococcal infections, meningitis, okay, and also brain abscess and staphylococcal pneumonia, toxemia, etc. Empirical therapy, what is the right choice, Dr. Narmada?
Yeah, as we already discussed.
Multiple choices are there, multiple drugs are there. Can you elaborate?
Yeah, first, the thing is that any invasive staphylococcal infection, we have to think about definitely adding on vancomycin with due credence to what Dr. Chitkara says with the new evidence which we will discuss later. But as of now, most of the international guidelines have started with the vancomycin and have advised.
Why do you add a beta-lactam
Yes.
when you are using vancomycin?
Yes, I am coming to that because we are also seeing methicillin sensitive staph aureus also producing an invasive staphylococcal infections which are coming from the community, and there are a lot of reports for that. So in the initial stage when the patient just comes to us, and of course with the background of having no exposure to a hospital there, we may be dealing with an invasive, a very virulent MSSA also. Not adding a beta-lactam here has definitely showed that it does not stop the mortality if you're just starting only with the vancomycin. Starting only with the vancomycin in a background of an invasive MSSA could actually increase the mortality
Combination
rate.
with
So
beta-lactam.
combination with the beta-lactam
In
is
fact,
what is
there are
reduced.
studies which have shown beta-lactam addition might even help in MRSA also.
MRSA also
Okay,
in
go
this
ahead.
condition. After that, as you rightly pointed out, in those conditions when you are suspecting, in the initial stage you could add cloxacillin. Adding on a ceftriaxone has been found to be a little inferior choice when you do not have the evidence for the same. So here it is like this one will hit the staphylococcus hard if it is going to be sensitive, and if it is going to be methicillin sensitive here, MSSA here. So this one also you can then with the advance of latest things which was already discussed, we are going to get the culture within 48 hours. We know the sensitivity pattern. Then we are going to step up or step down the treatment.
Well, none of the panelists will disagree if a patient with invasive staphylococcal infection, if there is hemodynamic instability going to ICU, combination of vancomycin plus cloxacillin or even linezolid is not incorrect.
Yes,
Am I right?
yes, sir. Yes.
Okay. Now, let us move to the case scenario 3. This is actually a 2-year-old, fever for 3 days, right knee swelling, pain, warmth, total count 28,000. Okay, child is suspected to have some bone and joint infection, high counts, X-ray shows joint space widening, ultrasound shows left knee effusion with septation. Dr. Chitkara, what do you think is the diagnosis? What is the bug? And what do you do, particularly with regard to antibiotic choice? Now you are suspecting a bone and joint infection, I
The
suppose.
first bug which comes to your mind is Staphylococcus. A close competitor is his strep pyogenes. So therefore, if I know these two bugs, I have to use a gram-positive antibiotic. Now coming from a community adenoseptic arthritis, I would expect it to be MSSA and start with, like we mentioned, either cloxacillin injectable if we have, or we can alternative is cefazolin. I leave it to you. There is nothing choosing between the two. So that is how, but this is a clear-cut case of septic arthritis and that would be our choice.
Okay, your orthopedic surgeon has done an arthrotomy. Your microbiologist is very smart. Within 24 hours, she is calling you and telling you with the report. Please interpret the report and what is your antibiotic choice? Dr. Chitkara.
Okay, so this is an MSSA and done by disc diffusion. I accept it is an MSSA, number one. Number two, however, I would have expected MICs to be there. So sometimes a drug may appear to be sensitive, but when you use, probably your doses or your compliance with those doses may really cause a persistence of a bacteremia, even if you think it is only MSSA. So therefore, do you want me to go on to bacteremia? We were on septic arthritis. So that report, MICs we would expect, very important when it comes to an MRSA reports, which doesn't give us a MIC, especially
This
for
is
vancomycin.
MSSA. This is MSSA.
Yeah, so here it's okay, I accept that, but then MICs are always, if we make it a habit to have MICs, because automated also is done, so I should have access to both.
Between the two, what would you choose if both are available? Both are difficult to get, cloxacillin as well as cefazolin. If you are able to get both, what would you prefer?
Clox.
Clox. Agreed. Agreed.
MSSA melts with clox.
Excellent. Excellent. Okay. Now, when it comes to anti-staphylococcal penicillins, the only disadvantage of cefazolin is that it may not penetrate well into the CNS like cloxacillin. Otherwise, both should be good enough for bone and joint infections. Okay? Right. Now, let us move to the next case scenario. The 13-year-old boy, it is put as case number 5, it is actually case number 4. The 13-year-old boy, he had fever only for 2 days. He was toxic, he was icteric, heart rate was 200, respiratory rate 40, he was hypotensive, hypoxic, and on examination he had an ulcer like this on the back of the left side. Retrospectively, they gave a history. There was a pustule which burst open to drain pus and form an ulcer 7 days prior to the onset of these symptoms. So the whole thing had happened in 2 days. There was some abscess somewhere in the body which had spontaneously burst open, and the pus was drained. Okay, this is the story of the boy, 13-year-old boy. He has tachycardia. He has what looks like a septic shock. He comes into the ICU. Now, Dr. Abaisha, what do you think is the diagnosis in this case,
so
and what is your antibiotic choice?
Yeah.
What choice for this patient?
So this is
and
a
why?
very classical situation. Any skin infection or travel injury to skin, followed by shock-like situation plus multi-organ failure. So this triad is very typical of a toxic shock syndrome. And the common organ is caused by Staphylococcus aureus and the Streptococcus pyogenes. Here there is a history that the child has having some ulcer and some pustules there. So whenever there is a pus formation, I think staph has always got a priority over the staph. So to me, it seems to be a staph MRSA. So naturally, I would like to end toxin. So I would have covered staph plus toxin, both I will cover. So the ideal drug would be in this case, we have vancomycin because the child is toxic. So I need to cover a drug which is bactericidal and has a
So
good
what is your choice here?
Yeah, so it is vancomycin and clindamycin.
All of you agree on this triple drug therapy for this patient? Chitkara, you want to disagree?
Vancomycin and clindamycin.
I agree. In fact, I would go with clox, vanco and clinda.
Yeah, I think here in a very sick patient with septic shock in whom you suspect toxic shock syndrome with the staphylococcal, you want to cover MSSA with cloxacillin. You want to cover what else? What else? Anybody? Is this combination, do you think, agreed? They said, what is the combination you wanted, all three of you?
Vanco and clindamycin.
Okay. Wantonly, I didn't give the correct choice. The correct choice is cloxacillin plus vancomycin plus clindamycin.
Ceftriaxone is never a good anti-staph.
Absolutely.
Remember.
Absolutely. I don't think you should be using ceftriaxone for this patient. The choice, if it is available, only because cloxacillin is not available, we are forced to use other drugs. If cefazolin is also not available, you have no other choice other than use ceftriaxone plus vancomycin plus clindamycin. Okay. Now blood culture has grown MRSA. Dr. Abai, blood culture has grown MRSA. What do you do for this patient?
So now, I think probably we will not go for the cloxacillin. We will continue with the vancomycin and clindamycin. Vancomycin will take off MRSA and clindamycin will take out the toxin. But this child has a MRSA. Whenever there is MRSA bacteremia is there, I think you have to the follow-up is very important. So you will have a repeat culture after 40 to 72 hours, number 2. So I will look whether there is persistent bacteremia is there or not. And second thing that always look for the metastatic focus. So thorough examination, serial examination from the bone and joint is very important. And I will also go for the echo because sometimes they may end up in having the infective endocarditis. So these two things are very important. So close follow-up, repeat culture is very important. And third one is the look for the metastatic focus. And if there is some tissue involvement is there, debridement, local care of the wound, all this source control is very important.
Interestingly, literature search, yeah. That's a very valid point. Even in staphylococcal skin scalded syndrome, you rarely get a staphylococcus from the blood. And very interestingly, most cases of both staphylococcal skin scalded syndrome as well as toxic shock syndrome is often due to MSSA rather than MRSA. So very stable patient with skin scalded syndrome, you need not go for vancomycin. It's enough if you try only cloxacillin rather than big guns. Okay?
Sir, 1 minute.
Yeah.
And remember this blood culture, I think streptococcus are more prone to having positive blood cultures, nearly 15%. And for staph, the blood culture is going to be more negative as far as toxic syndrome is concerned.
Agreed. Okay. Now let us move to the next case. It's a pretty long case, but we'll try to finish it as fast as possible. True case, this child had some lower respiratory infection, required HFNC support outside in a nursing home, and became afebrile, and again started having fever for about 15 days. And somebody treated with piperacillin tazobactam for 7 days. CRP was very high, and they thought it is atypical Kawasaki and gave IVIG and was referred to us. So this is basically a child with a background of a lower respiratory infection, given antibiotics, then after hospitalization developed fever, prolonged fever, treated as the IVIG as atypical Kawasaki and received 1 week of piperacillin tazobactam and came to us. On examination, this is a 2-year-old child. The child was febrile, alert, pallor was there, a soft systolic murmur was there in the left sternal border. Systems otherwise were within normal limits. This very stable child. And initial blood counts were high, hemoglobin is low, platelets are holding on, CRP was 58, urine was normal, X-ray was normal, renal and liver function tests were normal. Okay, the liver function test and renal function tests were normal. Blood culture was done and report was awaited, and the report came like this. So basically a background of prolonged hospitalization outside, fever 2 weeks, a systolic murmur, and blood culture growing MRSA. 2 blood cultures simultaneously took from 2 different sites, no contamination. So this is MRSA, and this is the report we got from the lab. It was sensitive to vancomycin, teicoplanin, linezolid, gentamicin, cotrimoxazole, and chloramphenicol, and resistant to cloxacillin, MRSA, ciprofloxacin, etc. Now at this point of time, what we did, what we had was the dilemma in choosing the antibiotic. This is the lab report. Now can any of you help me decide the antibiotics in this situation? Dr. Joshi.
Yeah, so I think this is a situation where a bacterial infection has developed on a predisposed initial viral infection, and it is likely to be, the MRSA is already grown. Now given the choices, since it is not a lung infection, we would not be keeping linezolid as a choice. Oral cotrimoxazole will not be helpful for MRSA. Vancomycin, linezolid could be an option, but the best option here to begin is vancomycin, because we have a MRSA and we have a child who has shown worsening. This child was treated, I really felt why he was given Piptaz for 7 days is really not understood, and he was been given IVIG. Now
so what is your choice for this patient?
I will start with vancomycin.
Only vancomycin?
Only vancomycin to begin with.
Chitkara, is it only vancomycin or vancomycin plus linezolid?
Initially, since the child is hemodynamic decompensation, if I remember correctly in that particular case, I would try to cover for the toxin also. Vanco per se, Vanco is the standard regimen for a bacteremia or a septicemia, but to cover for the toxins, initially few days maybe I would add linezolid, and otherwise even if I do not have those hemodynamic decompensation or other, even vancomycin alone, or if I am bothered, then vanco plus linezolid. That would be my choice.
Dr. Narmada, the lab also gives a report that it is MRSA sensitive to tetracycline, MRSA sensitive to cotrimoxazole. Why not start on IV cotrimoxazole or IV doxycycline is available?
No, sir. The vancomycin, if you are having a hemodynamic instability, then vancomycin
Suppose
is the drug of
hemodynamically
the
stable child, will you give cotrimoxazole or doxycycline for MRSA?
Not for MRSA, sir.
Not for MRSA. Okay, that's a very valid point. For MRSA bacteremia, you should not be using either cotrimoxazole or doxycycline. Is that right, Dr. Narmada?
Yes, sir.
Okay. You should not
Sir,
be using.
sir, one more point.
Yeah.
Linezolid is better than vancomycin for bacteremia?
I think we are coming to that in the next.
Chitkara,
sir,
you're
will
keeping
say
quiet.
Linezolid.
I would not enter into that debate, but I will say the standard recommendation and the standard which we follow as of today is for a bacteremic illness, it is vancomycin. Linezolid is non-inferior, and this data existed even before 2010. Now it is coming in a big way, and some of the meta-analysis 23, there is no difference in mortality or hospital stay if you use any one of them, but still that medical hesitancy, we stick to vancomycin as of date, in spite of the fact that we have to vary of the nephrotoxicity of it.
Agreed. For many reasons, adult infectious disease experts are reluctant to accept linezolid in spite of evidence that linezolid is as good as vancomycin for bacteremia. They want to restrict the use of linezolid for bacteremia. They want to use only vancomycin for bacteremia as the gold standard. Okay. Now, this child we started on vancomycin, loading dose for plus maintenance dose, and of course we measured the trough level, which is 13 milligram per liter. Don't ask me whether I know how to interpret, I don't know. And vancomycin, our team looked into literature and saw several adult papers and then increased the dose to 70 milligram per kg. Regarding vancomycin, I am going to ask Dr. Narmada. There is a lot of confusion regarding use of vancomycin. Many people say if you use vancomycin, you have to do the one, you have to assess the MIC. Second, you have to do the trough level. Okay, and which of the statements do you think is true, Dr. Narmada? One is trough level monitoring correlates well with the efficacy. If you measure the trough level and if it is good, you don't have to worry, it will work very well. Second is area under the curve bar MIC correlates well with efficacy. Third is trough level is mandatory. Without trough level, you should not be giving vancomycin at all. Four, it is exhibits only concentration dependent killing. Dr. Narmada.
So, for this one, it's a very important question here. Vancomycin, both the trough level and minimal inhibitory concentration is equally important. What happens is, if you have seen here, the minimal inhibitory concentration was 1. You have to assess, there are certain drugs that they have to maintain the drug levels throughout the treatment period. So that is what is determined by the area under the curve. Having said that, if you want to make a rough calculation of the area under the curve, you use the trough level calculation here, which was about, I think earlier it was about 15, if it just multiply it approximately into 20, it becomes about 300. So what was recommended by the international guidelines is to maintain it about 400 to 600 level milligrams per liter. But suppose you have a minimal inhibitory concentration of about 2. This 300 divided by 2 will become 150. Then that concentration is not adequate to kill the bug. So what you will be doing, you will be increasing it in similar way where you will increase it to about the 70 milligram. That time it leads on to the adverse effects. So we have to monitor the adverse effect on one hand as well as balance your the area under the curve. So in this condition, if you look at it, the levels are, you are increasing the levels high, so you will have to monitor for your adverse effect. So both the area under the curve and your minimal inhibitory concentrations are required in the bedside surgery.
So the correct statement is area under the curve
yes,
under and
will be with the
MIC.
figures.
So how many of you have estimated vancomycin trough level in your practice? Please raise your hands, including the panelists.
We don't deal, sir.
Minority. If you ask me, I have also done it. Only thing is, I don't know how to interpret. I listen to more intelligent people around me, youngsters.
Sir, but now I think we cannot say that we will not monitor, because if you are going to do, it's a very, it's a calculation with most of the labs can give us the vancomycin. If you are efficient enough to handle such cases, I think you should be calculating, otherwise we will be missing
the message is for such complicated cases, please take the help of more intelligent people like Chitkara, Sham Kukraja, etc.
No sir. This is Greek for me also.
Yeah.
In spite of the fact that we are working in a tertiary care, at the best we can manage is only a trough level after 1 or 2 days of stabilization.
Yeah.
That is the best we can do. Rest
Yeah.
all is Greek for me.
Please do the assessment of trough level, check with your microbiologist the AUCA bar MIC and go ahead. That's a message to all of you. Now, it has been proven that the trough only monitoring with a target of 15 to 20 milligram per liter is no longer the gold standard. That's what is reported in the literature. Drug level monitoring, it has to be done. It may be expensive, difficult to interpret, but you better do it when you are dealing with such cases. So this case,
when you get the trough level, area under the curve is just roughly up into 20, sir. So it's easier to maintain it that way.
okay. Now I'm going to ask Chitkara. You have started vancomycin for this patient. What about repeat blood culture? They say that you have to repeat blood cultures certainly in staphylococcal bacteremia. Unlike typhoid, we don't repeat blood cultures. Once the patient becomes better, we just do nothing. But in staphylococcal bacteremia, even if the patient is clinically better, you are supposed to repeat. When do you repeat? When do you repeat the blood culture, Dr. Chitkara?
So this is one condition where repeat blood culture is recommended after 48 to 72 hours of starting what you think is the most appropriate treatment with an MSSA or an MRSA diagnosis. Now why is this important is because this is a bug which just after having that bacteremia would settle down at various places which would not be apparent at that time but would be a reason for its persistence. So therefore document blood culture negative in a staph sepsis before you decide on the duration of the treatment.
Absolutely. This is one peculiar recommendation. That is in staphylococcal bacteremia, even if the patient is better, you have to repeat the blood culture. Chitkara said 2 to 3 days. The current recommendation is exactly 24 hours, 24 to 48 hours. If you don't repeat, you can be taken to court. That is the current recommendation. And if the patient continues to have bacteremia after 24 to 48 hours, that is considered as refractory staphylococcal bacteremia, you will have to step up the antibiotic. Now, Dr. Abhay, I am told that in staphylococcal bacteremia, unlike enteric or UTI with bacteremia, some other investigations must be done. What, why, how?
So we need to look for the persistent bacteria number 1, and if there is persistent bacteria, there is refractory, they are all told. So metastatic foci is very common, and so we'll go for the 2D echo, and also the bones and joint involvement also there, and sometimes even if the child has a little CNS point of view, sometimes CSF and a funduses, these 2 or 3 are going. Among all this, I think endocarditis is very, very important, so 2D echo is a must.
Okay, congenital heart disease, suspicion of infected endocarditis, you should do echo, and all staphylococcal bacteremia, you should do an echo, and also get an ophthalmologic examination. Because this child, we started on vancomycin, we checked the trough levels, everything was okay. We continued vancomycin, repeat blood culture exactly 36 hours after, still continued to grow MRSA. At this point of time, Dr. Chitkara, why do you think, Chitkara, Dr. Narmada, why do you think there is bacteremia? In spite of vancomycin, good MIC, is not resistant, good trough levels.
There could be other causes that usually...
What are the other causes?
It could be the focus of infection is still, we have not drained it, or it is still there, that the vegetations are still there, it's creating the problem here, or it could have come in some other places, and it has been there in the ICU for so long. Maybe we have a secondary focus. We'll have to see whether the ICU protocol bundles, the infective bundles have been taken care. What about the venous site, everything, because if they develop in one site, it is always possible that they will develop in the other site also, sir. And as I already noted, we have been increasing the dosage of the vancomycin, so there may be...
What about vancomycin creep, Dr. Chitkara, during therapy?
Okay, before that, your question on metastatic foci, which may not be clinically apparent or symptomatic, yet would be discharging this thing, a staph into the blood. That is why the blood culture persistent. So therefore investigate extensively for these metastatic. Coming to the creep, sometimes those vancomycins with the MICs between 1 and 2, when you really use these vancomycin, what we call as a treatment failure. So probably that is what I understand with the creepiness.
In spite of the lab giving you report that it is sensitive, the MIC can go up during therapy. You can have a metastatic focus, you can have infected endocarditis, any of these things could
And
be happening.
source control.
Now we have to rule out metastatic focus. In this case, I will tell you, we actually we changed the antibiotic to daptomycin and ceftaroline, which is the new 5th generation cephalosporin, and child became well. Now, my question, we modified the treatment to daptomycin and ceftaroline, and we got away with it. There were vegetation. This is an infective endocarditis. We used to OPAT, outpatient antibiotic therapy. The patient became better. Now, this question is to Dr. Narmada and Dr. Chitkara. We initially said that you can use either vancomycin or linezolid. What is your opinion?
Yes, Chitkara sir has clearly told in favor of linezolid, but the recent evidence is what they are saying is linezolid is a one drug. See, in this case, when it can be a you already defined vancomycin resistant Staph aureus, the linezolid will be an effective drug. So it should be kept as a reserve drug and not used immediately. The second thing is about though the side effects are definitely less even when compared to the vancomycin, it is also used for a VRSAs, the resistant ones, as well as reserve it for because of the tuberculosis detail, and the studies in children are evolving still. So that is the reason we are doing that.
Okay. Now one last question.
I need to comment here, sir. Go back to the previous slide. All these references are till 2007. Much water. No, the last slide I said.
Yeah.
No, what he has presented. So I refer again to whatever I said in my previous comments. I will not repeat it, but much water has flown as far as staph is concerned in last 1.5 or 50 decades.
Okay, the message is find the source for bacteremia, clear the blood with adequate antibiotics, check the heart, treat long. And of course, I am going to ask a question which is to be answered in 30 seconds regarding the duration of antibiotics for various indications. Dr. Joshi and Narmada, quickly.
Yeah.
We have only 1 minute more.
So yeah, for impetigo, it is a topical antibiotic therapy which is adequate, should be given for 1 week's time.
Topical 7 days.
Most important thing is that decolonization is important if it is a recurrent infection. For uncomplicated skin infection, if the abscess size is less than 5 centimeters, if it is a single lesion, you can just do incision and drainage, no need to give oral antibiotic. If it is a complicated abscess, then of course one requires to give an antibiotic of a limited spectrum. For uncomplicated bacteremia, it is 2 weeks of broad spectrum anti-staphylococcal antibiotic cover, and as you said, we have to do repeated cultures. Till we get 2 negative cultures, we probably would be doing it. For pneumonia, it is anywhere between
7 to 21 days for pneumonia, 4 to 6 weeks for bacteremia, 2 weeks
And
for uncomplicated bacteremia, and 7 days topical for impetigo. Okay, so to take home as messages, we must be familiar with all these terminologies with microbiology, lab confirmation. SSTA is the commonest infection. Most of them require mupirocin. You will have to adopt drugs like cloxacillin and clindamycin for SSTA. Vancomycin is the gold standard. Teicoplanin, less nephrotoxicity, not for CNS infection. Daptomycin, not for pneumonia. Ceftaroline emerging as a safe option. And finally, scotrumoxol, doxycycline, no for bacteremia. Clindamycin is like Mohinder Amarnath, it has come back for MRSA. And source reduction is very, very important. Removing the catheter, draining the abscess, draining the pus is as important as antibiotic therapy. Thank you very much.
Just 1 minute with the chair, 1 minute, only 1 minute. If I don't have to use a drug, I will start with the side effects. If I have to use a drug and I am convinced, I will start with the effects. So that is precisely debate on vanco versus the linezolid is concerned. And when I was a resident, जिसको लामा कराना होता था, उसको LP के लिए बोलते रीढ़ की हड्डी में सुई डालेंगे, पानी निकालेंगे. जिसको रखना होता था, उसको कहते LP simple procedure, अभी ठीक हो जाएगा. So that would decide whether the patient stays या उसको लामा कराना. So therefore, it is entire our perception with scientific evidence in each other's favor.
So the linezolid vancomycin, it's the latest IDSA was also said that still evidence is required for the children. That is the one thing I told. That's a 2025 guideline, sir.
Okay, in fact, next 5 years we may have better drugs like tedizolid, ceftobiprole and televancin, etc. We may not be having this argument of vancomycin versus linezolid. We may have safer drugs. Thank you very much.
So thank you for this excellent panel on Staphylococcus. May I request the moderator and panelists, please go to the, Dr. Surendra, please hand over them the mementos. Achha, those of you who are staying in this hotel, please check out because it is checkout time is now. So now we will have a session on vaccine potpourri, and the moderator is Jaideep Chaudhary. I call upon the experts, Dr. S.G. Kashi and Dr. Arun Kumar Mangalik.
Well, you might be thinking another vaccine session, but I can assure you, when two of the very interesting persons are there as experts, Dr. Kasi and Dr. Mangalik, we will have it in a different way. Now, potpourri, as you know, is the flower pot that we have. It's always interesting and it always adds some color in your sitting room. So without wasting any time, I will straight go to Dr. Mangalik to start with. We will begin with DPT vaccine, the ever controversial vaccine, DPT. Now often we talk about resurgence of pertussis, and many of our discussion rests on the fact of that resurgence, and it has happened in many parts of the world. Dr. Mangalik, what could be the reason?
Well, thank you for the question, and this is multifactorial. There's not one single reason which you can point out to it. Well, it could be more awareness of the disease, particularly in areas like India. People are diagnosing more. We have better diagnostic facilities. Earlier we used to diagnose on the clinical aspect as well as absolute lymphocytosis. Now we have cultures, we have PCR. PCR fairly readily available, though the cost may be high. These are some factors. The vaccine efficacy is in question. The waning immunity is coming up. Again, the issue of whole cell and acellular would come in. There are so many factors which are there which could correlate together, and we see these resurgences coming up.
Yes, often it's told that the duration of protection, even with natural infection or with vaccine, is not long lasting. And Dr. Mangalik, that's why we are giving 3 primary doses, subsequently 3 more booster doses as intervals, and also reduced amount of pertussis vaccine. So it's 3 + 1 + 1 schedule of pertussis vaccine. Now, is it justified? Because considering the duration of protection, and some countries even give more Tdap vaccine. So what's the justification of so many doses?
Well, you answered the question yourself. The duration of efficacy of these vaccines, the waning immunity, it doesn't last. I mean, very rarely would you expect it to last for a decade. It would be maybe 5 to 7 years or so. So we give 3 primary doses, a booster at 1.5 years, a second booster at 4.5 to 5 years, and a third Tdap which we give at the age of 10 years. And as you said, some countries, and in our country also, we are following the policy of giving Tdap to every pregnant mother during every pregnancy. We don't have a policy of giving a routine Tdap every 10 years to adults, but in some countries of the world it is being there. So with these, it is not unjustified, though unfortunately in the government sector they are not giving pertussis probably even at 5 years or 10 years.
Right. Dr. Kasi, I mean, continuum with this question, I will ask for your views, and also whether there is any advantage of priming with a whole cell vaccine before the acellular schedule. Because we know that in India, maybe more than 90% of the children get the whole cell vaccine only, and maybe 5 to 10% get acellular pertussis. So, is there any advantage?
Oh, no, it's working. Now, going to the previous question, 3 plus 1 plus 1, for any pathogen which has a very short incubation period, you got to keep on giving boosters as long as the risk of that particular infection is there. For pertussis, the risk is there lifelong, right from the newborn till old age. But if you see the acellular whole cell, though you can't use beyond 7 years. If you look at acellular pertussis vaccines, due to immunological reasons which I'll discuss, the response of every booster starts reducing, so that beyond the 4th booster or 5th booster, the duration of protection is only 1 to 2 years. So there is no idea in giving boosters every 5 years or 10 years, although the risk is there. Probably when we have better pertussis vaccine, we may consider giving boosters every year like we are giving for influenza, because definitely there is a risk of pertussis. Now coming to the second question, we must remember that immunologically, WP and AP are totally different vaccines. The way the body responds is totally different. Now let's take it one by one. Now WP is a better stimulator of the innate immune response. WP vaccines have lipopolysaccharides. That stimulates attaches to TLR4, and then you get a TH1 and TH17 response. Acellular vaccines are purified components. They are very poorly immunogenic. They need an adjuvant. But what is the adjuvant? Alum. Alum goes via a different pathway, and you get a TH2 type of response. That is the first difference. The type of IgG subclasses. See, for a bacteria, for phagocytosis, it requires IgG1 and G3. Whole cell pertussis, you get a very good IgG1 and G3 response. For the acellular, it is IgG1, and with every subsequent dose, the IgG4 starts increasing. See, IgG4 is a tolerogenic antibody. Now, what it does is, tells the pathogen, you do what you want, don't bother me. So, the pathogen goes on multiplying. So, the efficacy of the vaccine goes down. There is one more component called the tissue resident memory cells. These are lining the lungs, and they are the first line of defense against attachment of the pathogen to the epithelial cells. WP cells are potent stimulants of TRM, so they can induce sterilizing immunity, so they can prevent transmission and induce herd effect. TRM cells are very poorly induced by acellular vaccine, so they cannot induce sterilizing immunity or transmission. You see, and we must remember this queuing of the immune response in different direction is something that persists throughout life. In fact, there is a study where they have taken adults, WP primed versus AP primed. They have given a Tdap booster 15 to 23 years later, and even at that age, that favorable skewing of the immune response towards WP is there. And now regarding priming with WP, there is an excellent study which came from Australia. There was a huge outbreak of pertussis in Queensland in 2005-06. They looked at the immunization status of those who suffered pertussis. And what they found was, those who were primed with 3-WP had the lowest attack rates. Those who were primed with AP had the highest attack rates. And it was intermediate in those who had used a mixed schedule. And even in those who had a mixed schedule, the attack rate was lowest in those who had received the first dose as WP rather than AP. This gave to the concept that probably priming in a schedule is far better if you are using WP vaccine. This basically is the background.
Yes, but thank you so much, sir. Fantastic explanation as always. But the main message is that we must give all the doses of DTP vaccine in whichever form.
Just one comment, and excellently explained by sir. Even if you look at the latest purple book of ours, it's very clearly mentioned that WP priming scores over AP prime.
Okay, so from this we will move on to...
Now regarding this, So should we give, if we are scared to use WP, should we give WP first and then AP is what I think is in the mind of most of the people in the audience. It is a practice which you can do at an individual level, but there are no recommendations anywhere in the world for interchanging of WA to AP in the priming schedules.
Thank you, sir. So we will move on to another very frequently discussed vaccine, and again, I would like to put this to Kasi sir. Now the serotype is a jigsaw puzzle when it comes to PCV, and the most debated right now are 6A, 19A, 22F, 33F. Specifically for Indian context, how important is this?
Okay, the first point is more is not better when you're considering PCV vaccines. Okay, because if you see there's a PCV 21, but it has serotypes which are not common in childhood, so more is not better. Now coming to this particular question, this question has arisen because there are now vaccines available, recently introduced, which have 6B and no 6A, with the claim that 6B protects 6A. Now how common is 6A? In the first study, pneumonet study, 12.5%. PDOP study, it was about 2.5. So if you take all the studies together, it's about 6.5 to 7%, which is a very, very large number. Second, does 6B cross protect against 6A? Answer is yes, but it is not total. 6C. In USA, when PCV 7 was being introduced, PCV 7 had 6B and no 6A. 6A also went down remarkably, but it went down by about 76 to 80%, not totally. Even in European countries who were using PCV 10, which has 6B and no 6A, 6A came down, but another monster arose, that was 6C. And 6C is equally bad. And in fact, in those countries who were using PCV 10 or PCV 7, whatever serogroup 6 was isolated was always 6C. There was no 6A and 6B at all. So does it cross protect? Yes, but there are other drawbacks of not having 6A in the vaccine. Now coming to 19A, I think there is no doubt, 19F does not cross protect against 19A. 19A is a terrible serotype, highly invasive, highly antibiotic resistant. You need 19A in any vaccine that is being used in our country. 22F and 33F are called replacement serotypes. Countries which have matured PCV 13 immunization programs, surveillance over the years have shown that 22F and 33F has become the first and second in the replacement serotypes. Mark my words, PCV 13 using countries. PCV 10 using countries, Synflorix, these were not so high on the list. We have reached almost 92% coverage for PCV 3 in our country. But it's only for the past couple of years. The herd effect still hasn't started. So from that point of view, whatever isolates have been studied, 22F and 33F, 1.2%, not more than that. So I think as of today, it's more important to have 6A rather than to have 22F and 33F in a vaccine.
I'll just add one line, Maybe 5 years down the line, we'll see much more of 22F and 33F.
I will go to the next question to you, Dr. Manglik. It's a very practical one. National Immunization Program uses 2+1 schedule of PCV vaccine. Why not the same in private practice? A very cliched question, but again, please highlight.
Yeah, it's a very practical question. The NIP says 6 weeks, 14 weeks and 9 months. Now, world over, lot of countries are using 2+1. In fact, UK is using 1+1 for the last 5 years now. So they're giving just one primary dose and one booster. Now, the difference there, in most of the countries across the globe, they are giving the boosters at 12 months plus, whereas we are giving the booster at 9 months. That is basically for logistic reasons. Now, there has been a wonderful review by, I think, Chang, very recently published, where they had 4 groups. The first group was, irrespective of the number of primary doses, 1, 2 or 3, there was a one booster given to all that in that group. In the other 3 groups, they were having either no booster given, only 1 primary, 1 secondary, 2 primary and 3 primary. Now the results which were shown, 94% was there in the group A, that were booster was there, and in the others obviously with only one primary and nothing else being given, it was much worse. The results show that irrespective of whether you give one primary or two primary, if you give a booster, the results are simply superb. And your question is, why don't we do it in the private practice? And in the private practice, we are giving 3+1. Okay, we are giving the booster at 12 months plus or maybe 15 months, and we're giving 3 primaries. The results are probably equivalent if you use 2+1 or 3+1, but maybe marginally superior is 3+1. So the best results would be with 3+1. That's why when the patient is in private practice, it's a one-to-one matter. You're expected to give the best to the patient. Cost is not an issue. So in those situations, obviously, 3+1 scores because that is supposed to be the best.
If we give two PCV is a primary series, then the protection for 6B and 23F is not optimum till the third dose is given. And that's the children remain susceptible. Dr. Kasi.
You just, now, when the WHO recommended that PCV
Sir,
should
a bit
be
brief.
used,
We have
when PCV should be used in all countries, they compared the two schedules. And what they found was 3 priming doses is superior as far as antibody titers. This difference is maximum for 6B and 23F for all, which is about 17 to 21%. For all the other serotypes, it is less than 7%. There are studies which have shown that IPD due to 6B is more when you are giving 2 priming versus 3 priming. We do not know what will be the difference as far as pneumonia, because pneumonia require higher antibody titers. So as of present day requirements in our country, I think 3 priming is superior.
Thank you. Dr. Kasi, child received PCV 2+1 in NIP. Now the parents have come at 18 months.
Absolutely no need for additional doses, because as Dr. Manglik said, once you're given the booster, whether you gave 1 or 2 or 3 priming doses, there is no difference, and these protective titers will last for at least the next 8 to 10 years. Studies have been done in Gambia. It will last as long as we need protection from pneumococcus.
So in 2+1, the third dose, which is at a gap of 6 months from the primary, is the booster. So that's all. So next we will move on to another vaccine which is often discussed nowadays, is the MMR vaccine. Dr. Manglik, to start with, if a child has received 2 MR in National Immunization Program, should we give 2 more doses of MMR?
Of course. The child hasn't received
when
the
and why?
The child hasn't received the third and the second M, that's the mumps. So you give the MMR doses after, if the child has come to you after receiving 2 MRs at the NIP, 1 month after that you give the MMR first dose, and the second dose preferably given at 4 years, because you need to cover up preventing mumps in the young adults, young children.
Next, Dr.
You need a second dose of any live vaccines to cover up for primary vaccine failure. That is an important issue. So you require at least 2 doses of mumps. Now if you see measles at 9 months, primary vaccine failure rate is about 15%. If you see chicken pox, primary vaccine failure rate is 18 to 24%. For mumps, it is 2 to 5%. So in this case, you require a second dose, but there's no hurry to give the second dose. You might as well give it at 5 years, where you will have extended protection.
Time since vaccination is important for mumps protection also. So again, Dr. Manglik, unvaccinated child exposed to a case of measles 2 days back, can be offered?
Yeah, that will protect. Within the first 72 hours you give it, it will definitely help you.
Dr. Kasi, now there is some discussion about the mumps strain in the MMR. So any comments?
Yeah. Now basically when you're talking about a strain, you look at 2 aspects. How efficacious, what are the adverse effects? Now we are talking basically about 3 strains, the LZ strain, the Gerillin strain and the Hoshini strain. These are the 3 that we are concerned with. Now when you compare all 3, as far as efficacy is concerned, there is nothing much to choose between them. Wherever they have been used, all of them have worked equally well. Now coming to the reactogenicity, Gerillin strain has absolutely no recorded aseptic meningitis. If you come to the LZ strain, there have been some reports, but a large population level study done in Egypt, where more than 200,000 doses were given, there was absolutely no reported cases of aseptic meningitis. Coming to the Hoshini strain, that is where we are having a little more, confusion. In fact, the studies done in Iran, where the vaccine was first used, they abandoned it because of adverse effect. But Japan is another country which is using, which are still using the Hoshino strain. So putting everything together, I would put the Geraldine strain and the LZ strain at almost the same level, and probably Hoshino may be a little lower as far as the adverse effects are concerned.
Okay, sir, thank you. So let's move on to another vaccine. Again, a lot of controversy, lot of discussion. We have more sessions on it. But Dr. Kasi, how robust is the data for recommending a single dose of HPV vaccine?
I think we have had this discussion yesterday, and I think almost the entire audience, I will not repeat.
I mean, there are some audience, left before
fine.
that session.
You'll have
So
some
just
new
to
people around here
update
today.
them very briefly.
Now, this concept that one dose may work first arose from the Costa Rican vaccine trial, where a post hoc analysis showed that as far as prevention of persistent infection is concerned, one dose was non-inferior to 2 and 3 doses. But this was a post hoc analysis. The second study was the IRC trial done in India. There also it was an observational cohort study which showed the similar results. But these two were not high-level evidence, so RCTs. So we got the Kenshe trial, the Doris trial, Escudo trial, Thailand study, community level study, and at least about half a dozen studies done in the past 3 to 4 years, which have definitely shown that one dose is as good as more than one dose for prevention of persistent infection. Persistent level of antibody titers have been shown till the end of 5 years. We must remember that when you talk about persistence of antibody titers, as far as HPV is concerned, the levels almost plateau. There are no ups and downs. That means the maintenance of antibody titers is not due to natural boosting. It is just that the original stimulus, the long-lived plasma cells, are continuously producing antibody titers. Now, till the end of 5 years in these RCTs, it's always been a straight line. So there is reason to believe that this will go on for a very, very long time. And it is for this reason that the data is now quite robust that one dose will be sufficient. The question is 6 months, 5 years follow-up sufficient to say that it will last for 20 years or 30 years? That is something only time will tell. But I think the data is very robust, and I don't think we should have any hesitation in adopting a one-dose schedule.
With this, I come. Yes, sir.
Yes. Now, as far as age, these recommend, of course, the age specific. Now, see, for HPV, we are talking primary of the primary age group, 9 to 14 years, but many of the studies, these RCTs are 9 to 20 years. In fact, that's the reason why WHO has said that single dose from 9 to 20 years and not just 9 to 14 years. ACVIP has recommended now, why not?
ACVI has recommended that.
Yeah,
The latest addendum has come.
I will come to that question. Let's just 2 more questions and I'll come. Now, point is that this single dose HPV study was mainly for prevention of cervical cancer. But we are also concerned with other cancers caused by human papillomavirus. Do you think it will also, the single dose will also prevent other HPV related cancers? And genital warts also?
Yeah, see, basically now, when HPV vaccine was first made, it was for prevention of cervical cancer. And even today, the major burden is cervical cancer. So at the public health level, we are talking only about prevention of cervical cancer. So I think all the studies have, focused on prevention of cervical cancer. But we must remember that even as far as the other HPV related cancers, there is no reason to believe that the pathogenesis is any different from cervical cancer. It is the same aberration of the epithelium, the HPV getting attached, entering the cells, and then coming up, oncogenic changes. Everything is the same. So there is no reason that if one dose works against cervical cancer, why it should not work against the other types of cervical cancer also. Because 3 doses worked well for both. And if one dose works as well as 3 doses, it should work for both.
Perfect.
I mean, there's no idea in waiting for proof. You know, you are going to lose time. Many boys are not going to get the doses then.
This brings to the next question: how important is HPV vaccination for boys? And the question that definitely you have faced many times: why not a single dose?
Well, boys, till now we were concerned only with the cervical cancers, and since boys don't have a cervix, it was considered not important for boys. But do remember, boys would be transmitting, they were the carriers, and then obviously we are having half the population would be transmitting to others. We cannot expect all boys or all girls to be monogamous. So with this issue in mind, we would like to cut down the transmission also. And why not single dose? I don't, one line answer would be, we don't have data or evidence to that effect.
Dr. Kasi, any opinion?
Yeah. Now, boys, I think vaccination of boys is different to carry forth the concept of a gender neutral vaccine. If you have a vaccine to prevent cancers in males, why not give it to males? Second, where are the women getting the infection from? It's from their male partners. So immunize the males, transmission will be less, herd effect will be more. In fact, they have found that if the coverage is anything less than 70%, male vaccination will definitely promote herd immunity. But if the coverage in females is more than 70%, as a public health benefit, vaccination of males will not be of much benefit. But we must remember, it's our duty to prevent cancers in males also. Males should be vaccinated, irrespective of whether there is public health benefit or no.
Dr. Mangalik, one question specifically to you. Are we ethically and legally right if we give a single dose vaccine to males?
Well, one, we need to follow the standard procedure, standard recommendation. We have a definite recommendation as of now from ACVIP. So there's no question of being legally wrong over there. If you do something off-label, something which is not recommended and something which is beyond your usual practice, then obviously it should be done with a one-to-one consent and explanation, informed consent and a written consent to that effect. Then only you are legally safe, otherwise you are not.
Yes, okay.
Any recommendation coming from a national or international professional body will hold weight in a court of law. There is no question of doing anything illegal if ACVIP or the WHO or even the CDC recommends one dose. Remember, even CDC, which is so particular about evidence for anything, is now adopting a one-dose schedule. Yes. Exactly.
Boys, yes. For boys.
Now the legal issue practically he wanted to ask, because there are a lot of people who will sue you just for the simple thing, at the drop of a pin they'll sue you. So you just need to protect yourself. If you're doing it something which is standard, that's perfectly fine.
My question was for boys. Yeah. Single dose boy.
A single dose boys. As of now, we don't have a recommendation of single dose for boys.
So if I give, am I legally wrong?
Well, if you have taken the consent, explain things to them that it may work. As of now, we can extrapolate the data which we have for girls. Though it is data is for cervical cancer, if we can expect it to be working very well, then in that situation, if you have written consent from them, you are legally safe.
ACVIP has not recommended, but the WHO, CDC, Australia, New Zealand, Canada, everyone using a one dose for males. So you have precedent. Maybe ACVIP has not recommended it. But I still feel you can definitely give one dose for males also. Yeah. 14, 15 years, that's right.
So,
that is not used because the DCJ has not licensed it for males because no studies were done in males. See, India has got a policy now that for licensure of any vaccine, you should have a study done in our country. The company is not interested in doing it, so they're not going to do it.
Just one last comment here. Yes, adding to what sir said just now, DCJ is very clear now. You must have enough data for our population, then only you will get the license. You cannot extrapolate the data from there to here.
So, thank you so much. Sir, more discussion of the dais. Thank you so much. We have a very important event right now. Thanks, my experts. So, very important event. We had an e-poster presentation yesterday. There were nearly 60 participants. It was judged by expert judges from all over India. We will have the prize distributions for the winners. May I request the judges for the e-poster sessions? I can see Dr. Anurag Agarwal, Dr. K.K. Arora, Dr. Devajit Sharma was here, Dr. Rasna Das, Dr. Mrityunjay Das, Dr. Vaibhav to please come up. The certificates and prizes, please. Any other, Dr. Rajsekhar, any other judges left out? Dr. Deepti, Dr. Janani, Dr. Deepti to please come up. So, we will first we will give the prize to the person who has occupied the third spot. Mind you, this has been tabulated after assessment by all the judges. The third prize goes to Dr. Arsia Islam Rose. Dr. Arsia Islam Rose gets the third prize. So Arsia, please come up. From here you can come up. So the judges will present the prizes. Please, Arsia. The second prize goes to Dr. Sayantan Mondol. Dr. Sayantan Mondol gets the second prize. Sayantan, please come up. The third prize is 5,000 rupees. The second prize, Dr. Sayantan Mondol, he gets the certificate and 10,000 rupees. And the first prize goes to Dr. Payal Chakraborty. Dr. Payal Chakraborty gets the first prize. She gets the winner's certificate and 15,000 rupees. And may I request all the participants to please collect the participation certificate from the reception counter. So all the participants to please collect the participation certificate. May I request the chairperson of the next session, which is a partnership session, Dr. Dibyendu Rai Chaudhuri, to please come up to the stage and chair the next session, which will be taken by two very popular speakers, Dr. Surendranath and Dr. Shamik Ghosh. So, Dr. Dibyendu Rai Chaudhuri is Professor of Pediatrics from Medical College, Kolkata. So, please chair the next session.
Good afternoon, everybody. Now we are going to a partnership sessions, and the first session will be by M. Surendranath sir, and the topic is changing scenario of hepatitis A in India. Sir, please.
Good afternoon. Congratulations to the Calcutta team for an excellent conference and the excellent attendance in the hall. That is one of the wonderful things which has happened during the conference. Nowadays we don't see many people in the hall. So, yeah. So this talk is sponsored by the GSK, in fact. So let us discuss why the hepatitis A vaccine is very important nowadays. Basically, there is a change in the epidemiology of the disease. The disease has progressed. It is happening more in the older age groups. So the hepatitis A in the older age group is likely to be more severe infection compared to the infection in the infants. Previously, we used to think that hepatitis A is not a lethal infection. We need not worry about it. And usually the children get infection and they have most of the times it is asymptomatic. It doesn't present as a severe disease in the infants. So what happened is, over a period of time, definitely the epidemiology has changed. We are seeing more of the hepatitis A in the older age group compared to the younger age group. Why this has happened, we have to see the epidemiology as far as India is concerned. We know that the disease is transmitted because of the poor sanitation, contaminated food and water, and sometimes sexual transmission has been reported. And another thing is, most of that is transmitted to the fecal-oral contamination of the water. So poor sanitation is one of the reasons for the transmission of the hepatitis A. Let us discuss about the sanitation 20, 30 years ago and the sanitation which is happening nowadays. We take precautions as far as the contamination of water is concerned, so that's why we are not seeing the disease more common in the infants now. So as far as the disease burden is concerned, almost 156 million acute cases, out of that 35,000 deaths occur annually. And 63% are acute hepatitis cases, 93% of the deaths have occurred in the low and middle income group of the countries. The incubation period is about 15 to 20. And this is what happened, age-wise severity, less than 6 years children, most of the times it is asymptomatic. They present with the vomitings and a low-grade fever and loss of appetite. And these people may not have the jaundice also, clinically. More than 6 years, sometimes they do present with vomitings, and 70% of the patients may develop jaundice after 6 years if they get the infection. And 24% of the hospital admission rates are less than 15-year-old, and 45% of the hospital admission rates for the more than 15 years. So what it shows that hospitalization is more common with the infections which occur in the later age groups, that is the adolescents and the adults. And this is what happened as far as the endemicity is concerned. So whenever there is a shift from the high endemic to the intermediate endemic and low endemic, the high endemic city is almost by the age of the 10 years, 90% of the people will get the infection and they have the antibodies in the serum. So seropositivity is 90% by the end of 10 years in the earlier years. Slowly it is coming that seropositivity at the end of 10 years is coming to 50%, that is intermediate endemicity. If the seropositivity of the 50% occurs at the age of 10 years, that shows that it is a low endemicity. The problem with intermediate endemicity is there is a population which are not protected because of the infection in the infancy. They may likely to get the more infection at the end of the adolescents and the adults. Whereas the low endemicity, they don't get the infection because the transmission is less. And the low endemicity, they get infected, they are protected for the lifelong. So when you are in the intermediate endemicity, you are susceptible for the infection. At the same time, the transmission of the virus is not reduced, and we get lot of outbreaks which is happening in India nowadays. So this is what happens. So most of the times, the infection has been seen in the older age groups compared to the younger age groups in India, and the complications are more when they get the infection in the adolescents and the adults. So this is the year-wise distribution of the seropositivity rates as far as India is concerned. We can see that in 1982, almost 90% of the children get seropositive by the end of 10 years. In 2022, almost about, let us say, 40 years after, 45 years after the period of 1980s, we are seeing only 50% of children are seropositive by the end of the 10 years. That shows that we are slowly moving to the hyperendemic area to the intermediate endemic area. The problem is intermediate endemic area. The transmission of the virus is persisting and the susceptible population are there, so we are likely to get the outbreaks. As far as the hepatitis disease is concerned, hepatitis A is the most commonest, and the next comes the hepatitis E. Hepatitis B and C are less common compared to the hepatitis A and hepatitis C. So in the recent past, I mean 2011 to 2018, if you look at into the hospital administrations, almost majority, 50% of the hospital administrations are in the adults compared to the children in 2011. The most of the times in 2011, the children are who are the people who got admitted into the hospital. In 2018, the statistics show that almost 15% of the adult admissions has moved to the 58%. Most of the times it is the adults who are getting admitted into the hospital. And if you see that Acute hepatic failure is more commonly seen with hepatitis A as far as India is concerned. Most of the children who are admitted with acute hepatic failure, a viral etiology is hepatitis A is the reason. So this, I have already told that, and 50% of fulminant hepatic failure is because of the hepatitis A. And this is an interesting study. What they have shown is outbreak reports as far as India is concerned in the high socioeconomic and the low socioeconomic. The slowly over a period of time, 1998 to 2017, so the disease pattern in the low socioeconomic has reduced, and the incidence of the hepatitis A is found to be more in the elder age group, which we have already shown that. And even in the urban and the rural ratio is also coming down, and both are equally susceptible because the hygienic conditions are better in the urban and the rural areas nowadays. So these are the outbreak reports as far as India is concerned. There are a lot of outbreaks, almost 84 districts outbreak is seen. The reason for this is, as I told you, that transmission of the virus is still there and the population are not protected till later age. That is the reason that we have the outbreaks. So these are the various outbreaks which have been reported as far as India is concerned. If you see the age groups where the outbreak is occurring, so most of the times it is occurring in the age groups of the more than 10 years. That means 20 to 40, 16 to 30, 16. All the studies have shown that the outbreaks occur in the adolescents and the adults. So epidemiology is shifting. The importance of the vaccination comes now. If you don't vaccinate the infants, they are likely to be susceptible for the infection at a later age because they are not exposed to the natural infection. That is the importance of the vaccination as far as the hepatitis A is concerned. So food handlers are the most commonest transmission as far as India is concerned. Worldwide is also same. And in the Kerala, they have shown that 385 cases have been reported because of the food handlers and 3 deaths have occurred. So protection strategy, as far as protection strategy is concerned, the vaccination is the most important aspect of the protection against the hepatitis A is concerned. And the food safety, adequate hygiene, water supply, and clean water supply and personal hygiene of hand washing is very important to prevent the infection. Apart from that, a good vaccination coverage is very important. And now there are several ways to prevent the hepatitis A. These are the various preventive measures, improving the hygiene, and the routine vaccination is important. So coming to the vaccination, we need a vaccine which converts a faster seroconversion, and we need a long-term protection because the hepatitis A is a different age groups disease. It is not only the childhood disease, and it should also act in the immunocompromised, and herd immunity should be there. So when you give a hepatitis A of the GSK Haverix, almost 79% of them are seroconverted by the end of the 13th day, and by 19th day there is almost 100% seroconversion when you give the vaccine. Why it is important is, in an outbreak situation, the Haverix A can be used as a outbreak vaccine to prevent as a post-exposure prophylaxis. So you can see the seroconversion rate is almost 100% by the end of 19th day. So the vaccine is going to act to prevent the disease as far as the individual is concerned if he is given the vaccine within 2 weeks after the exposure. So outbreak scenario, vaccination should be given in an outbreak scenario, and not only that, outbreak involves a small self-contained community. High coverage of potentially exposed persons can reduce the transmission of the disease and curtail the outbreak situation. So how long will it protect? There are mathematical studies which have shown that means the antibody levels are very well maintained up to 50 years with the 2 doses which the child receives at the 1 year of age. And in some of the countries they have shown that even a single dose of vaccine can reduce the incidence of the disease. In the Brazil, in the national immunization program, they have given the vaccine as a single dose, they have reduced the reduction of the disease. And at present, ACVIP recommends, as far as India is concerned, it should be given in a 2-dose interval, first dose at 1 year and the second dose at 1.5 years. 6-month gap should be maintained between the 2 doses. And once you take the 2 doses, almost you will be protected for 50 years as far as the mathematical models are concerned. When we compare the other vaccines which are there, This is a Havrix is a recombinant kill vaccine, and pediatric inactivated vaccines also there. There is one more live attenuated vaccine is there. And when you compare these vaccines, most of the vaccines are doing very well in fact. And as far as seroconversions are concerned, inactivated vaccine scores better than the active, live attenuated vaccine, because live attenuated vaccine takes a longer time for seroconversion. At present, as far as post-exposure prophylaxis is concerned, the inactivated vaccine is better than compared to the live attenuated vaccine. So this is the long-term persistence of the immunocompromised individuals. In the HIV positive patients also, there is data showing that as far as antibody levels are concerned, their seroconversion rates are very good, and 7-year follow-up have shown that they also maintain the very good immunological antibodies for the protection. So these are the various studies in different countries. What they have shown is after giving the vaccination, so 95% reduction has been seen in the protection, and there is some amount of herd immunity is also seen. The vaccinated population 95% and general population 85% protection level is seen. So that means there is some herd immunity, herd effect level is seen as far as the hepatitis A vaccine is concerned. The community level protection will be very good when you vaccinate more than 90% of the people. So this is the first licensed vaccination. 1992 is got the first approval. More than 85 countries are using. Almost 432 million doses have been distributed. Found to be very safest vaccine without any adverse events following the vaccination. Pre-qualified in 2013. And the dosage, as I told you, is a 2-dose schedule. Should be given to the children from the age of 1 year onwards. The summary is, globally there is a high burden of hepatitis A disease is concerned. Outbreaks can occur in both low and intermediate endemicity countries, and many risk groups are for hepatitis A infection coexist. Shifting the endemicity increases the susceptibility of the adolescents and adults to more severe disease. Havrix have demonstrated a well-established safety profile over 30 years, and the Havrix have up to 50 years predicted long-term protection after administration of the vaccine in children are concerned. Thank you. Thank you for your patience here. Yeah.
Thank you, Dr. M. Surendra, for exploring the unseen facts in hepatitis A vaccination and hepatitis A disease, and on the basis of disease burden and the susceptibility in the adult and adolescent, the much awareness and much vaccination is needed. You have explained it in a nice manner. Now our next topic is HPV immunization, and that will be done by Dr. Shomik Ghosh, the cervical cancer and beyond. Dr. Shomik Ghosh, please.
A very good afternoon, and thank you to the organizers and the sponsors of this particular talk. There's been quite a bit of discussion, I think, already on this particular topic, and with all the controversy that has erupted about how many doses to follow. So before I begin my talk, from amongst the august audience that is present here today, I don't have a Mentimeter, but can I have a hand meter about how many of you are actively using the HPV vaccination in your practice? Can I just have a quick show of hands? So that is so very encouraging for all of us today here to begin the discussion, because whenever we are talking about vaccinations, we are first going to be justifying as to whether this is a public health problem. If it is a public health problem, how best we are going to be addressing that public health problem and reducing the morbidity and the mortality. So that is what will be the purpose of the talk today. So we all know that the human papilloma virus is the most commonly transmitted virus of the reproductive tract. We do know that it mainly spreads through sexual contact. So that should give you an idea as to why both the genders need to be protected. What are the diseases that are caused by HPV? The entire emphasis, as Dr. Kasi was mentioning, is on preventing cervical cancer, because that is the large burden, which is a public health burden and which we need to reduce. But we cannot be blind to the fact that while we have got a method of controlling this problem, we are also looking at cancers of the vulva, the vagina, and also the anus. What are the types of HPV which are important to us? We can broadly categorize them into the low risk ones and the high risk ones. And as we are all aware, type 6 and 11, which are primarily the cause of anogenital warts, they are the low risk ones. And the high risk ones, that is 16 and 18, they are the ones which are responsible for nearly 70% of cervical cancers. Now here, I'd like to make a point that while 16 and 18 are responsible for nearly 70%, there is a 30% still group wherein other serotypes are also getting implicated. So we cannot, be narrowing our vision to thinking that if we protect with 16 and 18, we are covering the entire population. So HPV types, once again, this is expanding on the spectrum. There are more than 200 types, out of which about 40 types, if we've looked at the pathogenesis, they primarily invade. Most of them spontaneously regress. The ones which cause an issue, they get into the lining epithelium and can remain there for years together. Out of them, the ones which follow the path of oncogenesis, they are the ones which cause the public health problem. And as we have initially identified 16 and 18, like I mentioned from the previous slide, they are responsible for 70%, but there is another percentage which is close to 30%, where we need to be looking at the other serotypes, 31, 33, 45, 52, 58, and possibly a few more emerging ones. So when we are trying to develop a treatment, we have to be aware of the epidemiology. We have to be aware of what are the causative germs. By sheer numbers, India, whatever be the percentage of incidence, a 1.5 billion population is going to be facing huge amount of morbidity and mortality. So, from HPV related cancers, if the global mortality rate is around 50%, which is a very, very strong statement, because this is an illness where prevention has to be better than a cure. India is looking at a mortality of nearly 60%. So whether you look at cervical cancer, whether you look at vulval, vaginal, or even anal cancer, the mortality levels, whether globally or in India, rather than remembering the absolute values, the key take-home message is we are going to be encountering more than 50% mortality. And that is what should guide us as to whether we should take it up as a preventive health measure. So, once we've defined that there is a public health problem, how are we going to prevent it? And the first statement, which even the government of India has recognized and now incorporated this vaccination into the national schedule, is that a vaccination is required. So let us see what are the options we have as far as HPV is concerned. We are all aware of this, and this extended spectrum is something that we need to be looking at. I think some of us who would be interested, we could be looking at the changing serotypes in the last 4 or 5 years, especially from epidemiological studies, and we will find that since this vaccine has been there for nearly 25 years now, the common serotypes, wherever they have been well controlled, there is an emergence of newer serotypes. And this is something we have to guard for in the future. We've talked about the pneumococcal serotypes undergoing a change. There is no reason for us to believe that the HPV serotypes will not change in the future. So the increased armamentarium is something we need to be aware of. So the distribution, we still have HPV 16 as the predominant cause agent, HPV 18 as the next, but if you look at the rest of them, they are emerging, and over the next few years or in the next 5 to 10 years, I'm sure we're going to be having more studies which will tell us as to how important these strains are going to be in the incidence of HPV infections and eventually cancers. So, what is important is how are the long-term follow-up studies? And these long-term follow-up studies are our definitive guide to build up confidence. When this vaccine was introduced, and if I had taken a survey, say about 15 or 20 years back, I would have hardly had a few hands being raised. But because over a period of years, we now have follow-up studies which establish that very high titers are being maintained in HPV vaccination, even 10, 15 years down the line, it inspires confidence that the vaccination is essential. So if you look at the data, the base studies initially in all the age groups were for 3 to 4 years, but after that, the studies were extended to up to 10 years, and now in females between 15 to 26 years, where it was first introduced, we now have data up to 14 years. And these data clearly indicate that the follow-up effectiveness, now this is of course not data from our country, this is from the Nordic countries, but the pathogenesis remains the same. The population characteristics might show some amount of differences, but by and large, the maintenance of antibodies do inspire confidence. And now we have data till 2025, which was also presented as recently as March 2026. So the conclusions are that all the follow-up studies do point to persistence of the antibodies for now nearly 14 years and even 18 years post the 3-dose initial vaccination that we have done. It begs the question as to whether we can reduce doses. The debate is ongoing, the scientific process is ongoing, and now we are getting a few definitive answers that possibly a single dose may be sufficient. So this is just reinforcing the statement that long-term effectiveness and immunogenicity in adolescents and young adults have been conclusively demonstrated in all the eligible age groups. And we now have data, even with the 9-valent vaccine, which extends till 14 years and tells us the very same story, that please begin vaccinating your children if you haven't done it thus far. Do boys need HPV vaccination? We made an opening statement that this is through the sexual contact, and hence to reduce transmissibility, and even if it is a one-to-one decision that we need to take, we need to give the best to our patients, and if there is something which can protect a child against cancer, irrespective of the gender, we must give them that protection. So they do need it because Indian men, they account for 14% of the global burden. And the prevalence on warts is also fairly high. And in some studies, it has been shown it is higher among the men than in the women. So it may not be a cancer, but who would like to move around with the genital warts? So they can help in creating a herd immunity, the vaccination in men. There are no screening tests also for HPV infection in men, unlike women. So the only tool we have of increasing the herd immunity is to vaccinate. Practical challenges, I think so we are getting better. Public awareness, this data is slightly old. I was pointing it out that this is between 2017 and 18. I think so the public awareness has increased. The biggest proof is that the government has now decided to bring it into the national immunization schedule. Amongst healthcare providers, though the slide says it is limited, this audience at least gave us a thumbs up and say that they are aware, and hopefully it spreads to more healthcare providers peripherally with the government as a significant partner. So it is critical for us to educate the parents. We must recommend it like any other vaccine. We have to give them answers to their questions, and it is our doctor-patient relationship which will facilitate this whole process. Thank you so much for your very patient hearing. This is a sponsored session by MST, and I just hope I've been able to touch upon some basic concepts.
Thank you, Dr. Ghosh. By nice deliberation, you have finally depicted, considering the high mortality and morbidity of HPV-related cancer, how essential it is to increase the vaccination rate. Thank you, thank you.
Thank you.
Thank you.
Take questions.
So may I request the speaker and the chairperson to collect their memento from the memento corner. And our next session is on evolving landscape of dengue prevention. And may I request the facilitator, Dr. Puneet Kalra, to be here, and the experts will be Dr. S.G. Kasi and Dr. Ritubrata Kundu. May I request Dr. Puneet Kalra? Yes, he's here.
Good afternoon, everyone, and welcome. So, I'll be moderating this session on the evolving landscape of dengue prevention. I would like to welcome my esteemed co-panelists, Dr. Kasi and Dr. Ritubrata Kundu, and they actually require no introduction. They are stalwarts in the field of pediatrics and vaccination themselves. So, without much ado, I am a full-time Takeda employee. The vaccine TAC 003, which we'll be referring to in the slides, recently has approved DCGI approval. So, but it's not yet available in India. Okay, so when you talk about dengue, it's one of the fastest spreading vector-borne disease worldwide. Its incidence has increased to more than tenfold in the past 20 years, and there are multiple reasons behind that: the climate change, urbanization and population growth, and the increased travel tendencies which have happened post-COVID, so much so that WHO classified dengue as a grade 3 multi-country emergency last year, which requires highest level of public health intervention. And without going much into the stats, it's a disease wherein more than 3.9 billion people are at risk across 109 countries, 390 million infections, 5 lakh hospitalization, more than 40,000 deaths, and 1/4 of all dengue cases are asymptomatic, out of which almost 5% develop severe dengue and 30% have persistent dengue symptoms. It's a disease which comes in epidemics. It can overwhelm healthcare systems and can disrupt the travel plans as well. Talking about India, India happens to be the global epicenter of dengue, and some studies quoting that almost 1/3 of dengue cases occurring worldwide occur in India. It has a huge cost on our economy. Approximately 1.1 to 5.7 billion USD is the cost which accrues to healthcare system. There's almost a 50% seroprevalence of dengue in India. It's endemic in almost all states and among the leading causes of hospitalization. But then the fact of the matter is there's a massive underreporting of dengue. Every year, National Vector-Borne Disease Control Program reports around 2 to 3 lakh cases, but the actual number could be up to 282 times higher. This is what published studies have quoted. The overall case fatality rate of dengue is around 2.6%, and the seroprevalence varies from region to region. All 4 serotypes co-circulate in India, but dengue 1 and dengue 2 are the predominant serotypes. There's hardly any dengue 2, dengue 4 in East. Predominantly it is dengue 2. And dengue 3 is one of the emerging serotypes, but by and large it is dengue 1 and 2 which is predominating. So that brings me for the first question, that we all know that against dengue, which we would require an integrated approach, which would require vector control, surveillance studies, and an effective vaccine. That brings me to the first question, which is addressed to Dr. Kundu. Why do we need a vaccine for dengue?
Give me the next slide.
Yeah.
So all of you know that dengue has only vector control. We don't have any medicines against dengue. And dengue has a very high attack rate. It is one of the fastest mosquito-borne viral diseases. So when an attack of dengue comes, the whole system of hospitals and other system gets overwhelmed. The parents have to go from pillar to post to find a bed for their children. So that's one of the very important reasons why you need a dengue vaccine. And besides that, our country has a huge amount of mosquito-borne disease, and that's another reason. And all of you know that dengue has 4 serotypes, and the serotypes varies from place to place. Even in the same country it varies. So we need a vaccine which should give good coverage to all the 4 serotypes. And not only that, as you know, dengue has 4 serotypes, and there is a chance of having more than one attack of dengue. So a person who is seronegative or seropositive, both may have the disease. So we need a vaccine which will give a good coverage to both seropositive and seronegative. It has been often thought, so why not take the 4 serotypes and make a vaccine, attenuate them and make a vaccine. But adding 4 serotypes is a very great challenge. You cannot do that because one of the serotypes will predominate, and so that his immunogenicity will be much higher as compared to the other. So that's the reason a chimeric vaccine has been planned out. What we do, we take the backbone of dengue 2 serotype, and why of all the serotypes, why dengue 2 has been taken? Because dengue 2 has the highest occurrence over the country. So on these dengue 2 serotypes, we have added the antigens of other serotypes, so that we develop a chimeric vaccine which will give not only coverage to all the 4 serotypes, but it will give a homotypic protection, so that this protection is good enough and it lasts for a long time. So that's the reason why you need a dengue.
Okay. Thank you. So the next question, Dr. Kasi, what is the product profile of TAC 003?
Yeah. Basically, this particular vaccine, TAC 003, let's not take trade names now, is indicated for the prevention of dengue in individuals above the age of 4 years. The upper age limit depends upon country to country. It's been recommended right from 16 years to 65 years also. Like all live viral vaccines, it's given subcutaneously. It is given in 2 doses, 3 months apart. It's actually a lyophilized vaccine which needs reconstitution. Like any vaccines, hypersensitivity to any of the components in the vaccine is a contraindication. Being a live vaccine, any sort of immunodeficiency, whether it's congenital or acquired or symptomatic HIV or symptomatic with low CD4 counts, it's contraindicated. Like any other live vaccines, it's contraindicated in pregnancy. Because there are no safety data in breastfeeding women, what happens to the infant? As of now, breastfeeding is also taken as a contraindication for this particular vaccine. Let's go to the next slide, please. I think this Dr. Ritabhita has just mentioned about it. In this, the backbone of dengue 2 is taken. It is attenuated with 3 attenuating mutations at the 3-UTR, NS1 and NS3 regions. Dengue 1, 3 and 4 is based on the dengue 2 backbone. They have removed the PRM and M proteins of dengue 2 and replaced it with the PRM and M proteins of 1, 3 and 4. So we have a dengue backbone. Dengue 2 genetic backbone is taken because we want the maximum protection against that particular serotype, because that is the commonest serotype most frequently associated with severe disease. We must also remember that this vaccine has the NS1 protein as well, which was not there in dengue vaccine, because there the backbone was the yellow fever vaccine. And why do we need NS1? Because NS1 has been associated with disease severity. And NS1, there is cross protection between the different serotypes. So NS1 of dengue 2 is expected to give cross protection against NS1 of 1, 3 and 4. Yes.
Okay. So
this vaccine has been, as of now, this has been approved in 41 countries, but being used presently in more than 16 countries. Right from August 2022, Indonesia, then the EU where they got a positive approval. Then in December, it was approved in European from 4 years onwards. Then subsequently in 2023 is approved in Brazil, Colombia, Thailand, UK and Argentina. And in May 2024, it has been approved in additional few countries. WHO pre-qualification has occurred. And as Dr. Puneet mentioned, very recently, the subject expert committee of NTAGI has approved this particular vaccine, and it is going through the process before it can enter the Indian market.
okay, so on March 31st, the vaccine has got approval in Australia as well, and indication is again 4 years plus. This is the latest. Okay. So, Dr. Kundu, what is the immune response following TARC-03 and what is so typical about that?
So, if you see this vaccine, it's a live attenuated vaccines, and we know that there are 2 arms of the immune system. One is innate, another is acquired. Of the acquired immune system, again you know there are 2 types. One is humoral immunity, another is cell-mediated immunity. Now, if you take this vaccine, it will not only produce innate immunity, it will draw the macrophages and the wandering monocytes. So, to start with INF gamma, it gives not only good innate immunity, but also it gives a good humoral immunity. Of this, the humoral immunity, the most important is the antibodies against the NS1 antigen. All of you know NS1 antigen is liberated from the dengue virus, and it causes damage to the endothelial cells. One of the hallmarks of dengue pathogenicity is leakage of the plasma. And this leakage of the plasma leads to dengue shock syndrome. And this vaccine has a very good coverage, very good protection against this NS1 antigen. And these antibodies which are prepared against the NS1 antigen is of high avidity and high affinity. By avidity and affinity, we mean not only it binds very tightly with the epitopes, but it also binds with almost all the epitopes. It's just like a Velcro effect. If you attach a Velcro, you will find at every step it is very difficult to remove it. So it gives a very good binding. And moreover, on the top of it, it gives both type of cell-mediated protection. The CD4 cells and CD8 cells. Those virally infected, dengue virus infected cells will be killed by the CD8 cells, and the CD4 cells will help the B cells to develop memory cells, so that it gives a long protection, and this protection is a homotypic protection. Unlike the after having a natural dengue, you have a protection, but this protection is short lasting, and this protection is also of lesser good type, because it will cause antibody mediated enhancement. So in this way, this vaccine is excellent in all the fields.
Okay, thank you, Dr. Kundu. So
if you now see these antibody levels, so the usual cutoff antibody levels is, though there is no lower cutoff of this, is 10. But if you see in baseline seropositive individuals, the antibody level is high right from the beginning, and for dengue 2 serotype it is further higher. And not only that, it persists for as long as 4.5 years till the study was done. And for baseline seronegatives also, it gives a very good protection, with the dengue 2 serotype 2 more further. And as I was telling you, the antibodies are both of high affinity and avidity. Now if you come to NS1 antigen, give the next slide. If you come to the NS1 antigen, which is a very important antibody, because it prevents dengue main pathogenicity, in baseline seropositive, it is higher, and in baseline seronegative also it is good, more than 10 to the power log 10 to the power, and it shows this antibody level till 15 months. So it is a very good protection against this.
So thank you, Dr. Kundu. So Dr. Kasi, what is the global clinical developmental program of TACO3? Can you throw some light on that?
This vaccine has been very extensively investigated before it has entered clinical usage. The phase 1 to 3 trials have occurred in 14 countries, both dengue non-endemic and dengue endemic countries. Over 28,000 participants in an age group of 1.5 years till 60 years. And as the WHO has said, it has included a substantial proportion of seronegatives as well. And as you can see, the phase 1 studies have, 2 studies have been done mainly in the non-endemic, but the 3 main trials have been done in Latin America and Asia. And in fact, one of the phase 1 studies has been done in India as well. Next, please. Now, the phase 3 study, which is called the TIDES trial, that is the pivotal phase 3 study, was done in a population of 20,300, 4 to 16 years of age, where vaccine and placebo were given in a 2:1 ratio. And in the cohort, 72% were baseline seropositive, 28% were seronegative. 8 endemic countries, data was collected for all the 4 serotypes, and there is a published 4.5 years follow-up. Study was done in 3 phases. Phase 1 was done at the end of 12 months, where they looked at the efficacy, overall efficacy, vaccine efficacy, and vaccine efficacy against virally confirmed dengue. That is overall, seropositive, seronegative, irrespective of age, overall. At 18 months, the secondary efficacy endpoints were vaccine efficacy by serotype, baseline serostatus, severity, and efficacy against hospitalized due to virally confirmed dengue. And at 54 months, that is 4.5 years, there were the exploratory endpoints which looked at the safety and efficacy at the end of 4.5 years. It also looked at additional endpoints within the subgroups like different time points, 2 years, 3 years, 4 years, etc. It also looked at the age-related efficacy. What is remarkable, it was an active febrile illness surveillance. That means there was an active surveillance for occurrence of fever, both in hospitalized and in the community for patients who had either received the vaccine or the placebo. Next.
So Dr. Kundu, what is the efficacy of TAC-O3 against dengue?
So now show me the slide. So if you take the overall vaccine efficacy in virologically confirmed dengue and hospital confirmed dengue, you see that it is virological vaccine efficacy against virologically confirmed dengue at the end of 12 months and at the end of 18 months. These are more than 80%, 80.2 in one, and after 18 months it is 19.2. So all the primary and the secondary endpoints were perfectly met. Now let us come to the next one. So this is a vaccine efficacy studied against virologically confirmed dengue, irrespective of the baseline serostatus. That means whether you are seropositive or negative. If you see the curve, the upper curve shows the number of cases in the placebo group and the lower curve shows the number of cases in the vaccinated group. So if you see very carefully, just after giving the vaccine, there is a separation of the curve starts. That means the vaccine showing efficacy right from the beginning, and as the days goes by, years goes by, the efficacy gradually rises. So much so, the overall efficacy against virologically confirmed dengue at the end of 4.5 years, irrespective of seropositivity, is 61.2%. And this efficacy is going to save nearly more than 5,000 children per 100,000 vaccinated in seropositive group and more than 4,300 children in seronegative group. So it is a very good achievement. If you come to the next, this is what happens in hospitalized virologically confirmed dengue at the end of 4.5 years. Again, if you see, the vaccine efficacy is very good. The gap between the placebo group and the vaccinated group gradually increases. And for hospital admission, it has a very high protection level of 84%, irrespective of the serostatus. Come to the next. But so for seropositive individuals, the vaccine has good coverage against type 1, type 2, type 3, type 4. But if you see the seronegative individual, with type 1 and type 2, the vaccine efficacy is very good. But there was a problem with type 3 and type 4. It didn't show good result. Why it didn't show good result? Because when the study was done, there are only very few cases of seronegative person infected with dengue 4 serotype, only 3 cases. In such a huge study, 3 cases won't give any meaningful result. And so also in dengue 3 cases, there are only 16 cases, and where the study was done in Sri Lanka, there any virologically confirmed dengue, irrespective of severity, was admitted to the hospital. So it didn't give a good result. So for that, they have done further studies in further places, including more number of subjects, and the results are not yet published, but Puneet will definitely know the results, and if Puneet is good enough to share with you the results, then another feather will be added to the cap of this dengue vaccine. Jore, louder, we cannot hear.
Is it? Yeah. So, Dr. Kundu, since you asked, it's still data on file, but then we extended the 4.5 years follow-up to 7 years of follow-up with a booster dose. So the problem of 3 and 4 having, not uniform representation was addressed. So coincidentally, when we extended this 4.5 years follow-up to 7 years, there was an outbreak of Dengue 4 in Latin American countries. So against Dengue 4, we actually got an efficacy of 70%. Dengue 3, still the number of cases were not sufficient, but the negative results of minus 15.5, that negative confidence interval turned positive. So there's a trend towards positivity in Dengue 3. We are not making any claims, but as the sample size has increased, at least in Dengue 4, we've got some positive results. Besides that, we are doing some studies, phase 4 studies in the launch countries in Thailand, in Indonesia and Malaysia, wherein the specific focus is on Dengue 3 and 4 hospitalized cases. I think within 1 or 2 years, probably when the sample size against this Dengue 3 and 4 becomes statistically significant, we'll be able to give you more results. Yeah.
So Puneet, let me conclude it. The only drawback of this vaccine was that in seronegative subject, the vaccine didn't have action against Dengue 3 and Dengue 4, of which now the Dengue 4 shows good result after the studies. So now only one point is left, seronegative Dengue 3. I think that should also be settled within next few months when all the studies report will come.
Sure. Thank you. So
coming to the whole, summing up the whole thing, if you take the primary endpoint, that means 12 months after giving the vaccine, the vaccine efficacy as high as 80.2. The secondary endpoint, that means 18 months after giving the vaccines, is 90.4 vaccine efficacy. And if you follow the vaccine down, say 4.5 years, it is as high as 84%. So it is going to be a very effective vaccine, especially in India where the type 1 and type 2 predominates and there is hardly any type 4 and very few cases of type 3. So this vaccine will have its mark, and not only mark, it will leave behind a very good mark.
Okay, thank you. So let's come to safety, Dr. Kasi, if you could sum up, how safe is the vaccine?
I think safety of this vaccine was something that was eagerly awaited, because the previous dengue vaccine, Dengvaxia, caused a very significant number of disease enhancements in those who were seronegative, specifically 3 to 4 years after taking the vaccine. So it is imperative to prove that this vaccine is safe. Incidentally, in the part 3 of the pivotal phase 3 trial, both baseline seronegative and seropositives, if you see the adverse effect numbers, they are similar in both the vaccinated and the placebo, both in the seropositive and seronegative. Less than 0.1% discontinued due to any reason during the trial. There was no evidence of enhanced disease which was found with the previous vaccine. There was no increased risk of hospitalization, and there was no death reported due to the vaccine. This is per se important, no increased risk of hospitalization, because in the phase 3 study there was something to suggest it, but subsequently in the PMS that has been done, there has been absolutely no risk of increased hospitalization with the vaccine.
Okay, so I'll be quick.
Now coming to the 2 doses, now this is a live vaccine, so why 2 doses? Now you require 2 doses because you want seropositivity against all the 4 strains, and what they found was that in baseline seronegative individuals, after 1 dose, seropositivity was only 85.3%, which increased to 99.4% after the second dose. Hence, and the 3 months period is the period that is most optimal for the second dose, where the antibody titers induced by the first dose will not be significantly affected by the second dose. So the 3 months interval has been found to be the best.
Okay.
Yes, there are co-administration with hepatitis A, yellow fever and HPV vaccine, where antibody level response to either of the components of either TAC003 or the other vaccines were not significantly affected by co-administration. So it is now definitely recommended for co-administration with these particular vaccines. And that's it.
That's it. So
you can take over.
So I'll just sum it up. by saying that, so see, in terms of vaccination, we moved from vaccine to vaccination. The vaccine being approved in 42 countries, more than 24 million doses being given. The primary endpoint of 80.2% vaccines against symptomatic VCD and 90.4% against hospitalization achieved up to 4.5 years. The real world data trends are showing that the vaccine profiles, wherever it is being launched, in Brazil, Argentina, Colombia, they match the clinical trial results. And, and recently we have finished our Indian study, DEN 302 Indian studies, and there have been effectiveness studies which are emerging from Brazil as well. So I think, and from Argentina. So all in all, the trends of clinical trials which we saw on the vaccine safety and efficacy are being replicated in the real world as well. So we've actually moved from vaccine to vaccination, and this brings me to the end of the talk. Thank you so much, Dr. Kundu and Dr. Kasi, for this wonderful talk, and thank you for being such a wonderful audiences. Thank you for staying with us. Thank you.
I would like to thank all our experts. Our next session is on extended spectrum pneumococcal conjugate vaccine by Dr. Arun Kumar Mangle. We'll start our next session at 2. We will start our next session from 2 p.m.
এটা তো স্লাইড চেঞ্জ So good afternoon everybody. After a really good lunch, we still have around almost what I can take a head count, maybe around 80, 90 odd 100 people around, so that's great. Post lunch, half the people would like to sleep. So it says extended spectrum of conjugated pneumococcal conjugate vaccine. So what do we mean by extended? When will the extension end? So this is the disclaimer, and it's a partnership session. So this is what is happening to the extensions. We started off with 7. We had 10, 13, 14, 15 in the pipeline, available abroad, 20 already here, not yet licensed for children, 21, 25 may be coming up soon. So will it ever end? I just wonder, because we have around 100 plus serotypes for pneumococci. Are we going to target 100? Remember, the bug is smarter than us. The organism is smarter than us, because what we are trying to do is trying to fight nature, and nature will always defeat us. So what is the bug doing? You add another serotype, it changes the other serotypes, gains predominance. So that's exactly what is happening. And another aspect we must remember, the more serotypes you add, it adds to the cost. It will add to the volume, the amount of volume you got to inject. And remember another thing, the more serotypes are there, the efficacy of individual serotype vis-a-vis a vaccine which has got less number of serotypes will decrease. So if you have P7 having serotype 6B, and if I have P20 having serotype 6B, the efficacy of 6B in P20 will be less than that of same 6B when it is in P7. That is well known, but thankfully it is not of much clinical significance as of now. But if we continue to add the serotypes after this, then maybe we may end up with problems. So I don't know what's the solution to this. The solution can be in later stages, maybe 2 decades from today, that you can eliminate those serotypes which are totally out of vogue, like we've come up with trivalent influenza vaccine because the Yamagata strain is not there. So you may consider eliminating those. So this could be done. So for the next 15 or 12, 13 minutes, we'll talk about this, what the vaccines available to us, what are the serotype coverage by various vaccines, the issue of 6A, 22F and 33F. We've been listening to this since the last since yesterday, and a bit of data on P14. So this is what we have. P7 is gone, 10, 2 brands of 10, 13, 2 brands of 13, the time-tested vaccine for the last 15 years or so, Pfizer, and we have the 14, and we have another Chinese vaccine which is 13. So how do they fare? Some serotypes are missing or lacking in some vaccines, like in P10, GSK doesn't have 3. Well, 3 is not present in P10 both. Well, 3 is a very difficult serotype. It has got a very hard core, and though it's present in P13 and 14, but the problem is the efficiency of this serotype is poor, and it's still sort of, it just brobeats science. So this is what we have. The issue of serotype 6, because that is one big issue, 6A and 6B. We heard Dr. Kasi talking about that 6B does cover for A by a cross protection. It has got 4 serotypes now, A, B, C, D. A, B and B were well known. C came up in 2007, maybe 18 years from now. It's modified from 6A. Some genetic modifications have occurred. And D has been lately identified in some Asian countries, and it is a modification from 6B. So the debate continues whether there is cross protection. Well, one thing is sure, there is some definitely cross protection. Whether that is absolute or not, that's a conjecture. Obviously, a direct protection may be in the long run better off, but that does not mean that 6B doesn't protect against 6A, primarily because of a structural similarity, and you can see over there the structural differences are very minimal. Okay, just because of the linkage between the differences between Rhamnose and ribitol. Now this is data from the time-tested P13 vaccine, which is there for the last 15 years, 16 years, 2010. So what does this say? It is recommended that any PCV which has got 4 micrograms of 6B is shown to produce functional antibodies, that is good OPA levels against 6A in a majority of children. And this is what the vaccines have got. Okay, so P13, Pfizer, Chinese, both have got 4.4, and P14 also. So this is, and you can see on the right box over there, you can see over there that the OPA is 90% for 6A, which despite the fact that the vaccine did not have 6A. This is from P7 data, because this is from Pfizer itself. This is our own publication, and Pallab is there. I don't see him here right now. He was one of the authors, and what do they mention in that? In this review, which was published only last year, that PCV7, which contains 6 serotype 6B conjugate, but no 6A, it displayed a strong OPA response to type 6A as well as 6B, definitely, and a partial response to 6A. So this is the, as they say, the taste of the pudding lies in the eating. So when you see this data, what is there? Once P7 was introduced in the USA, what happened to 6A? 6A was not there in that vaccine, P7. It was only 6B which was there, and you see a 91% reduction in the incidence of 6A, and you can see year 2004 to 2006, that is the data. And so you see on the study highlights, 6B containing vaccine was incorporated in 2000, and the incidence of 6A invasive pneumococcal disease under 5 years was decreased by 91%. And even there was some herd immunity developing. South Africa, we have similar data. The 6A, the baseline was 131 cases per lakh. It came down to 52 over a period of maybe 5 years. And so 6B containing vaccine, which was incorporated in 2009, following that, the 6A reduction was as high as 62%. Now this is not absolute. Maybe we are not happy with 62 or 90, maybe we want 100. Remember, we cannot achieve 100% with any vaccine. Please note this, there is nothing like 100% on earth. There is only one thing which is 100%, that I have to die. You have to die. That's only 100%. Nothing else is 100%. It can be 99 point several times 9, but it cannot be 100%. So another important issue is what was the minimum needed effect for. Now 0.35 microgram per ml is considered the correlate of protection, but if you consider for various conditions like invasive pneumococcal disease, you can see in the second box, it's only 0.16. For acute otitis media, it's 0.25, and for nasopharyngeal carriage, it was 0.51. So we need a higher antibody titers for nasopharyngeal coverage. And what did we find in PCV14? It's 1.08, so it's covering up much better. Of course, it's less than that of P13. And the OPAs, you can see again, it was more than that what we have for P7. So the scores above P7, definitely less than P13. Nasopharyngeal carriage, well, this is the WHO SAGE position, which is very clear that the 6A nasopharyngeal carriage has been substantially reduced. And nasopharyngeal carriage is very important because this is the cause which transmits. All of us have got grandchildren or children at our homes. Particularly the elderlies have got grandchildren. If the child has got in the nasopharynx some pneumococci, you're liable to suffer, and an adult, 60, 70-year-old plus, who's got diabetes and maybe hypertension, then he's liable to end up with some problems. So look at the 6A was only 2.19%, and just an hour ago, Dr. Kasi was clear that is around 6% as of now. So, and see, imagine this. This is very, very busy, but I have just by intention I have projected on the right the 6A evidence with P14, and you can see the post booster evidences both are very similar. The red block is P13, the blue block is PCV14. 22 and 35, well, yes, they are less in number, but they are emerging serotypes. They are coming up because they are non-vaccine serotypes. So they will come up, and maybe 5 years down the line you will see more of them. So they are there in the top 5 non-vaccine serotypes everywhere, all over the world. And you have enough data and evidence for that. So they are emerging. In India, in the nasopharyngeal carriage, they are around 2 to 4%, but it will definitely come up as time passes. And this is another important thing is the presence of the biofilm, and so they have a lot of resistance. So if you have a P22F or 33F infecting you, then you may land up with some serious problems, and the bug may be antibiotic resistance as well. So this is the non-susceptibility data from the US over a period of 20 years when they did a core surveillance. So the importance lies in the fact that though they are only 5% or 3% or 4%, we have data from abroad which shows that they have reached 10% plus because of serotype being changed, because the non-vaccine serotypes are now coming up as I say, selection of serotypes, and they have high invasive capabilities. So imagine this, had 22F and 33F not been important, why have some companies coming up with now